And it's my privilege to take you through all your obstetric unit this year. So we're starting off with antenatal. We're going to move in a logical progression. So yeah, this is me and my family. I'm married to Kayla. We've got 4 kids. Some of them are probably your age. By way of background, I was a nurse and then a remote area nurse on a remote island of Indonesia for a few years and in outback Queensland for a few years. And then about 12 years ago, I came back to Tassie and became a midwife. So I worked at the LGH for a while, and then I went back to uni and did extra study to get my endorsement, which meant I could set up in private practice. So I've been working across the road at the Launceston Birth Centre for the last 7 years, offering home birth and full continuity of care as a midwife. So, and I've also been invited to, present this to you. I've got a background in teaching and, sort of conferences and run workshops and things for midwives as well. I was named Midwife of the Year in 2024, so hopefully I can meet all your needs for this coming year. I sat in to see what was taught last year and I've sort of rewritten and revamped the whole program. I wanted to make it a lot more practical. So I know anyone here knows they want to be an obstetrician. I know you're still early on in your training. No? Not sure yet? Well, it doesn't matter, whatever area you work in. At the moment in Australia, 6.3 million females are of reproductive age. So whatever area you go into in medicine, you're going to come across pregnant women at some point, highly likely anyway. So this hopefully will be relevant to you as you move through your career paths. Okay, this is going to be a very interactive session. Please, if you have any questions, interrupt me and ask. But I want to start off with a bit of a story. I want you to imagine that I've asked you to go down to the mall, either Brisbane Street Mall or Elizabeth Street Mall in Hobart or another mall in the world. And I want you to do a poo right in the middle of the mall in front of everyone. How many of you feel you'd be able to do that? You'd start. I know that's what you're thinking. All right. Some of you probably could because you would just be so busting that no matter who's there, you'd just be able to go, right? Maybe. But most of you are probably going, no, probably not, right? Yep. Okay, it's all right though, because I'm going to show up and I'm going to have some lube and I'll have some gloves and I can help you if you need. I might have some aperients to give you. Does that make it feel a bit better? You can poo in the mall now? No, probably not. Still probably not your preference, right? Okay, so have we got a problem with physiology here? Something wrong with your body because you can't poo in the mall? So if I said to you, no, I want you to poo at 3 o'clock, I'm going to tell you the exact time I want you to poo. Does that help or make it any better if you know if I give you a time? No? Okay. Well, it's all right. I'm going to let you just poo when your body's ready in the privacy of your own toilet. Now do you feel better about that? Right. So what's that got to do? Sorry, my daughter's just dropping something off, so I've left my phone on. What's that got to do with pregnancy? Well, I want you to always come back in pregnancy to think, well, first of all, let me ask you, is pregnancy physiology or pathophysiology? Physiology. So you need to always come back to that whenever you're working with a pregnant woman. What does she actually need? What's her body trying to do? Because the conditions that we create around physiology can change it. It can either work or it might not work as well, right? Like trying to poo in the mall or in your own toilet. So do you really need to go and see a gastroenterologist for a normal bowel motion? Do you need to see a surgeon for a normal pregnancy? And I would propose that obstetricians really are surgeons. They're trained in managing what's not normal, and I'm so grateful that we have them. But if everything is normal, is that the pathway we need to be going? Yeah, so I want you to keep coming back to constantly asking yourself, what is her body trying to do here and how can I support that? Yes, we're on the lookout for pathophysiology when we need to step in. And we just want to remember that the woman here is at the centre of our care. Her body is doing what it was designed to do. So let's think about how we can support that. This is me when I was pregnant with my last baby, and that cow is pregnant too, so we had matchy bellies. And that brings me to woman-centred care. Has anyone heard of that term? No, so it's quite a big catchphrase in midwifery. I don't know if it's in medicine as much, but I hope it will be after you've finished with me. So the word midwife means with woman, and I'm always conscious of that when I'm working with women. I'm not showing up as the expert. I might have a lot of knowledge and skills in how to support her, but she's the expert in what feels right for her. So midwife means with woman. What I learned when I was putting this presentation together is that, excuse me, obstetrics comes from the Latin word obster, which means to stand by. What a beautiful combination, right? Like we're with woman and we're standing by to see, does she need some input? What input does she need? We're not just assuming that we're going to come in and manage her. And just always remember, she's not just a pregnant belly. We're always talking about a human here. And sometimes it helps me to think, especially because I work in private practice, women hire me, they pay for my services. And so I'm not set up above them, I'm there serving them. They've hired me, right? And even if you're working in the public system, someone's paying you, even if the woman's not directly paying you, she's essentially hiring you. So find out what she wants and needs from you rather than assuming you know. Okay, so this is the plan. So today we've got 3 classes split throughout the year, 3 hours each. So today's all antenatal care. And at the end of the year, you'll have an OSCE, I think, around taking an antenatal history. So the 4th class in September, we have actors come in and we set up scenarios and you get to do like a mock OSCE. And yeah, so that's what this whole today is all about. And then the other 2 classes, we're going to do about 4 hours on labour and birth. So that'll spread over the next 2, like the next one and then some into the next one after that as well. And then 2 hours on postnatal care. So we'll just progress logically through. And then our learning objectives today. So by the end of today, hopefully you'll feel more confident taking an obstetric history and performing an examination, describing routine antenatal care, detecting what high risk or higher risk pregnancy might look like, understand and explain the common screening tests and when they are offered, prepare individualised plan for antenatal care, manage common pregnancy problems, and then counsel lifestyle modifications using motivational interviewing. Any questions so far? I was told this is meant to be a taste or an introduction. You'll go into more depth next year, but you'll have a few pracs, I believe, this year. You're doing GP placements or, yeah. So you highly likely come across women presenting to the GP for their first appointment. So hopefully this will help you feel more prepared for that. And just come back to this is always personal. So let's put today's lesson in the context of Sarah, who's a 28-year-old. So she comes to her GP at about 12 weeks gestation with her first pregnancy. She reports mild nausea and fatigue, but is otherwise well. She has no significant medical history, but mentions that her mother had gestational diabetes. So as we work through today, I want you to think about what key aspects of her history would you want to explore and what examinations and tests might you want to prioritise at this first visit. So why does antenatal care matter? What are your thoughts on that? Pretty call out.
Prevention of avoidable pathology.
Yeah. Anything else?
General like information and reduce anxiety in the mother.
Yes, beautiful. That's a great answer as well. Yes. Anything else? I know for me, in my context of practice, it's also very much about safety and it's relationship-based care. If I'm going to offer home birth to a woman, I want to make sure I know her well. I don't accept clients that come to me at 38 weeks pregnant and say, I didn't need you for antenatal care, I just want you to show up for the birth. I feel like I'm walking in blind to that situation. And so antenatal care also creates the opportunity to build a relationship and a rapport with the woman you're caring for. It helps her maybe be more open to considering what you're suggesting to her or recommendations you might make, because there's trust there. It's a two-way relationship. So pregnancy and birth is a normal physiological process. Why do we need antenatal care? Well, like we said, it improves outcomes for mums and babies, and it helps us prevent a lot of common things. And this is actually how we stand by, right? Like if obstetrics is standing by, this is what standing by looks like. Not just ignoring her and letting her just do her own thing. We're being observant. We're seeing what's going on. What does she need? And 90% of maternal deaths are prevented by quality antenatal care. Regular antenatal visits reduce preterm birth by up to 24%, and it helps us notice if there are some conditions that are developing that actually mostly can be managed very safely if we know about them. And we'll look into some of those a bit later. Okay, so coming back to Sarah, how might Sarah know she's pregnant? This can't be Sarah because I think she knows already. It's pretty obvious. But early in pregnancy, what are some, like if she, what might make her go to the shop and do a pregnancy test, buy a pregnancy test? How might she know she's pregnant?
She's missed her period.
Yep, she might have missed a period, amenorrhea. Yeah. What else? Does that always happen?
Always. Sometimes you can get a little bit of bleeding. People
Yeah.
might think is that.
Yes, exactly. What else? How else might she know she's pregnant? Even before she's missed her period, some women have some signs and symptoms.
Nausea and vomiting.
Is that? Yep.
Nausea and vomiting.
Nausea, yep. Nausea and vomiting, yep. What else?
Planning, like they've planned it.
Yep.
They might just do regular tests.
So these are some of the common things that women report early in pregnancy. Missing a period, nausea, tender breasts, that's often before you've missed your period. Some women get that anyway before every period, so they may or may not pick this up, but during pregnancy it's usually a lot more intense. Fatigue, women report a lot of just feeling very tired in that early part of pregnancy. Frequent urination. Anyone know why that might be?
Uterus get bigger and push on the bladder.
Yeah, definitely later on in pregnancy. Yeah, I suppose early in pregnancy it's bigger than it ever was. That's true. There's a couple of other main reasons for frequent urination. What does progesterone do? Have you guys looked at hormones yet? A little bit. What does progesterone do to smooth muscle? Relaxes smooth muscle. And so it acts a bit like a vasodilator, and it means the bladder doesn't have as much tone. And in pregnancy, a woman's blood volume increases significantly by sometimes up to 50%. So she's got a whole heap more circulating fluid, so that can add to frequent urination. Implantation spotting. So when the fertilized egg implants into the uterus, sometimes she has some spotting at that time, which can be mistaken as a period, but often it's a lot lighter than that. Cravings and aversions. Once again, that's from all the hormones, particularly HCG, human chorionic gonadotrophin hormone, which is your main pregnancy hormone. Constipation and bloating, that's also progesterone's fault. And smell and taste, same thing, and mood changes. So these some of the signs that might make her want to go and get a pregnancy test or come and see a GP. So then Sarah has to decide what's next. So she'll probably go to a GP, and then it's up to you as a GP, if that's the area you're working in, to know what care options she has. Where does she go from there? So these are the ones relevant to Launceston. In Hobart, they have a few other clinics in the public, like a bariatric clinic, and their team midwives is called Kim, Know Your Midwife. So there's some variations, but this is Launceston based. So public health options, midwifery group practice. So that is where women can go through the public hospital but have a group of 2 midwives that will see them for all appointments and be on call to come in for their labour and birth, and then look after them postnatally. So that's probably the best continuity of care model that you can get through the public system with a midwife. You all heard of the term continuity of care? It's gold standard care when it comes to midwifery and obstetrics. Having the same care provider, or as close to as possible, a consistent care provider, as opposed to fragmented care where you see someone different at every appointment, which makes it hard to build a trusting relationship. And continuity of care, definitely in all the research and literature, shows way better outcomes for women and babies, satisfied, and better actual physiological outcomes for them as well. So we're wanting to get as close to continuity of care as possible when we're talking pregnancy care. So MGP is probably pretty much gold standard in terms of public healthcare options. In Lonnie here, we also have a CMC, a collaborative maternity care clinic. That's for any women that have particular challenges. They may be especially young, like teen mums, or they might have financial struggles. So pretty much anything that it's called Women's Plus here, the antenatal clinic is called Women's Plus. Anything that they determine someone needs a bit of extra support, they might be offered CMC. There's an endocrine clinic. So if a woman develops diabetes or has an endocrine disorder, she'll usually have her appointments in the clinic with the doctors in there instead of seeing midwives. And then there's just a general doctor's clinic. They'll often just do booking-ins or random one-offs when the midwives determine that this woman might need some doctor input or just extra eyes over what's going on. And they have an outreach clinic as well. So they have midwives setting up in places like St Helens, Georgetown, I think Deloraine, Beaconsfield, so that women don't have to keep travelling in. They can have a lot of their appointments in these outreach centres. And then team midwives is a team of, it used to be about 10 midwives. I don't know how many now. And the idea is that every antenatal appointment you meet one of these midwives, and then hopefully one of them will also happen to be on birth suite when you go into labour, and so that you've met at least them once. So it's a form of continuity of care. It's not as great as MGP, but it's they're trying. So I used to work in team when I was in the hospital. But then you've got private options. So obviously private obstetrician, you have to have had your private health insurance for about a year before you can use that to have private obstetric care. You can also do GP shared care. So some GPs, especially the bubble, but a lot of GPs who are interested in women's health will share care between the hospital. And so the women will go to the GP for a lot of their antenatal appointments and then come to hospital to birth and then go to the GP afterwards for follow-up. And then there are endorsed privately practicing midwives. That's me. So because I went back to uni and did my endorsement, I have a Medicare provider number and a prescriber number. I can write scripts, I can order ultrasounds, blood tests, write referrals, a lot like a GP would, but just in midwifery area. So women can just self-refer to someone like me, and I care for them their whole pregnancy. I'm on call for their labour and birth, and then I look after them for 8 weeks doing home visits afterwards. So that is gold standard of continuity of care. But once again, that comes at a fee, and private health doesn't cover that, so women are out of pocket for that. Medicare give rebates for the antenatal and postnatal component, but not enough to cover the whole lot. So women are usually out of pocket $5,000 or $6,000 for a service like that. And then doula. Has anyone heard of a doula? What's a doula? I saw some nods over there. Yeah, do you want to answer?
They're not a medical professional, surely, but they do help and provide support.
Yeah, and lots of the community get confused between doulas and home birth midwives. I've done 10 years of university, so I'm highly trained and qualified. A doula has usually done no university or medical training around pregnancy care. They're a support person, but they have no regulation body, so they offer education, support. It's kind of like hiring a friend to look after you and just have that. Yeah, it is. They're wonderful. I kind of wish all my clients would hire a doula. A lot of women who are birthing at the hospital will hire a doula so that they have a consistent person with them, knowing that they might just get any old random person that they've never met when they're going to labour. And even in home birth, like they have continuity with me, but sometimes births might go for 24 hours and I can't be at my best if I've been with a woman rubbing her back for 12 hours before she's even really got into the harder part of labour. So I love it when there's a doula that can give that kind of support and care to a woman. Some doulas are just postpartum doulas, so they don't do birth at all, but they will show up afterwards and they provide meals and massage and they'll look after your baby or clean your house for you. So they have a very important role, but it's also important not to mistake them as medical caregivers, and some doulas overstep that boundary. But most doulas are wonderful. So yeah, I just thought I'd highlight that here. So Sarah's come to the GP and the GP will hopefully lay out all of these options for her. And this chart, so Melanie the midwife is a doctor of midwifery research based in New South Wales, and she's put together this. It just shows, like, from this end, this is free birth. Has anyone heard of free birth? Free birth's when a woman decides to have no care provider with her and she'll just birth at home without a midwife or often without antenatal care. Often it can go really fine because, once again, physiology works well in an environment where someone feels relaxed and safe. It's like pooing in your own toilet. Often it will just work, but it can have disastrous results as well because there is no one standing by. There is no one with her to notice when things move from physiology into pathophysiology. So free birth, home birth goes right through to having a booked planned cesarean. So you're looking at the least intervention right through to the highest amount of intervention and sort of continuity of care right through to fragmented care, although, yeah, no care for free birth. But yeah, we just know that who you choose as your care provider has a huge impact on the outcome your birth has. So if you end up with a cesarean birth, it's not necessarily because you were always going to need a cesarean birth, unfortunately. Like I said earlier, if you choose a surgeon to care for you, if you have a private obstetrician, you are much more likely, according to the research, to have surgical intervention in your birth. It makes sense. Obstetricians and surgeons, that's their tool bag. My tool bag is supporting normal physiology. So if you choose me to care for you, you are much more likely to have almost no intervention and a normal birth unless it was really needed. So it's just important to bear that in mind. People don't often realise that. The caesarean rate in Australia at the moment is between 36 and 41%. The World Health Organization says that anything over 10% is not associated with better outcomes for mums or babies. So what does that tell you? That a lot of women are having unnecessary caesarean births. Privately practicing midwives, that's what PPM is. Our caesarean rate nationally is between 13 and 18%. And the Launceston Birth Centre across the road's been going for over 40 years. And I collated their statistics a couple of years ago because I thought this would be really interesting. And our caesarean rate has remained at about 5.1%, which is what the public caesarean rate was 40 years ago. So yeah, who you choose as your care provider makes a difference as to what kind of birth you have. So antenatal care matters.
Sorry, really quick question. With you, the type of care that you specifically offer, does that mean that all the women that give birth at home, or do you have like a place that they can... So
there's a little, if you look out the window, you can see it. It's that grey house there. Out that line, it's right there. That's called the Launceston Birth Centre. So it's a house. It's like an Airbnb for birthing in.
Oh, okay, yeah.
And so women can either birth at home, but if they live far away, like on the East Coast, I won't go to the East Coast to do births because it's too far away from a backup hospital. So each midwife has their own comfort level. All my women have a backup booking here at the LGH, so that if something suddenly becomes less than ideal, we come over here to birth. So yeah, it's a conversation that we have between each client and myself as to, will you birth at the birth house? Will you birth at home? Will you birth at the hospital? And sometimes we don't decide until we have a birth plan meeting in about 36 weeks, depending how the pregnancy has progressed. So Yeah, I'm not doing that this year. There's 2 more midwives, thankfully, because I've been on call day and night for the last 7 years, and that was a lot. So I got a bit burnt out from being on call, so I'm taking a break from that this year. But while it was just me, I was the only one qualified in Launceston and a lot of northern Tasmania to do this kind of care. I was turning away 100 or more women a year, and I just encouraged them all to use the birth house, because if 2 women went into labour at the same time, I can't be in 2 places at once. But there are 2 or 3 different spaces in the house that we can use. So I could sort of call in second midwives and juggle that better. So any other questions about care providers?
Do you think that the increase in C-sections is due to like being scared of a normal birth, and that's why it's happened over, like you hear 1 or 2 stories about like a 3rd-degree tear or something like that, and people don't want to like trust normal physiology?
Yeah, I think that's huge. I think in society, what we see on TV makes us scared of birth. We see women screaming and it's not very realistic. I can tell you now, we'll get into this when we do birth next time, but most of my women are very quiet having babies. It's peaceful. They're often in the water. They're really in their zone and empowered. But I would say generally, I know like when I had a couple of babies at the hospital and then 1 home birth myself, I was very scared as well. Having said that, if you're in the public system, you can't choose to have a cesarean unless you have a significant mental health challenge and you've negotiated for that. If you've hired a private obstetrician, you can. So some women would definitely go down that path, maybe because of stories they've heard from their women in their family or friends, for sure. I think the rate is also high because we do a lot of inductions and we're trying to get her. It's like me telling you to poo in the mall at 3 o'clock. We're saying, right, your baby's due to come now and her body's not ready and therefore it doesn't work very well, and therefore we have to jump in and help. And often that will then lead to more cesareans. And then because so many women have had their first cesarean, a lot of them don't even get offered the option to come back. And hey, this is my daughter, everyone.
Like a grand entrance.
Yeah. I wanted a Doppler and I forgot to bring it, so she just brought my whole birth kit. If anyone wants to have a baby right now, we can. Yeah, because women have had their first cesarean, they're often just offered a second cesarean for every subsequent pregnancy. So of course the rate then snowballs. Whereas a vaginal birth after cesarean, also known as a VBAC, is very valid option, but lots of women don't realise that and it's not. So, any other questions around? Yeah.
I've got a question because you worked in a hospital and
Yes.
then now privately.
Yes.
Home births. Have you noticed, like, so obviously you can have epidurals in hospital. Is there any like need or difference in the pain management that women choose between hospital and choosing?
Yeah, that's a great question. I know lots of people choose some sort of medical pain relief in the hospital and it's not available in a home birth. I can technically prescribe morphine, but I will never do that in a home environment. Like if women want pain relief, I say I'll come with you to hospital and support you in hospital. Having said that, women who are going to invest that much in a home birth or a home birth midwife are very well prepared. Like they're highly motivated. They've done the inner work they need to prepare for birth. And so I don't find they need it. Probably warm water is the best pain relief, being in a quiet, calm environment with people you love, calm music. No one looking at it. There's no clocks anywhere in the birth centre. There's no time pressure. We just let it unfold. If mum's well and baby's well, we just keep going. And so all of those things help a lot. And so women aren't screaming during birth nearly ever in a home birth. But I think in a hospital, it feels like a very foreign environment, right? Like we often only go to hospital when we're sick, injured or dying, or someone we love is. So we already walk in those doors and there's tension, fear, all of those things make it harder for your body to work. You actually have more pain and therefore are more likely to need pain relief. So that also becomes a cycle. Yeah.
So it's not uncommon for, or common for women not to have any pain relief when giving birth?
Very much so, yeah. If they all have no pain relief if they're out of the hospital. Sterile water injections, but it's just what it sounds like, and I'll explain what they are next time, but that would be the highest amount of pain relief we'd offer other than massage, movement, warm water. Any other questions about care providers?
I was gonna say, so say that you were over at the centre and you had a mum who needed to come up to the hospital.
Yeah.
How does that work in terms of the fact that you're a private midwife and you go in? Is it like they still let you do everything as the midwife, but the
Not in Tasmania, so
Yeah.
that's called visiting rights. So obstetricians, private obstetricians are a bit like me. They have their own private practice, but they have visiting rights or admitting rights at the hospital. And it's a contract they have with the hospital so that when they come in, they can be the care provider for their clients in the hospital. In every other state of Australia, there are admitting rights for private midwives, endorsed midwives like me, but Tassie haven't got that going yet. So at the moment, if I transfer a woman in, as soon as I walk in the doors, I'm a support person and I can't be the clinical care provider. The hospital, I have a really good relationship with the hospital here and they know me and they trust me and I respect them and they respect me, and so it works well. But it's not like that in most of the rest of Australia. It's often tricky for private midwives who transfer in. There's a lack of understanding as to what we do and how qualified and skilled we are, and therefore lots of people think home birth is unsafe and just sort of demonise all of us. But that'll change. It's just awareness. I used to think home birth was terribly unsafe too, so I totally get why people have that perspective. So yeah, at the moment we don't have that, but it's coming. They're working on contracts and documents for that to make it easier. So yeah. Okay, so Sarah's come to the GP and she's thinking about you know, what's next. What might she present with when she comes and sees you for the first time? What are some common pregnancy challenges you've heard about?
extreme nausea.
Gestational diabetes.
Yeah. Some of these things are probably would more move into the higher risk. So what would be some common pregnancy things that maybe don't require too much medical intervention, but she might complain about? That makes sense.
Back
Anxiety.
pain.
Anxiety, yeah. What else?
Back pain.
Back pain, yes. Yeah, back pain. We talked about a few of them, I guess, earlier, but. So yeah, nausea and vomiting, heartburn. And women complain of heartburn, constipation, hemorrhoids. Once again, it's thanks to progesterone, all that smooth muscle relaxant and vasodilation. Everything just goes a bit blur. Cramps, varicose veins, fainting. Do you know why women feel faint during pregnancy, even when they're sitting down?
Low blood pressure.
Yep. Even though their blood volume's increased, they've got low blood pressure because of what? Vasodilation. Yep. And your inferior vena cava, the baby as it gets bigger and bigger, the weight of that, if it's in a certain position, sort of presses back on that inferior vena cava. And even, I remember sitting at the desk over here at the hospital writing notes during one of my pregnancy and just suddenly nearly fainted. Hadn't moved for a while, just sitting. I thought, that is so weird. You'd expect it when you stand up or you're walking around, but it was the pressure of the baby on my inferior vena cava. It makes women feel faint. Carpal tunnel syndrome. That's usually from the increased blood volume, extra fluid, pressure on nerves, and then edema, swelling of the hands and feet. So all of these things can be considered normal, and most of them would resolve after the woman gives birth. They often don't need medical management, not too much. But you always want to be looking out for red flags in case it progresses further than that. So we're going to consider physiological change. We're going to get to taking a history in a minute of Sarah, but we want to consider before we go into that, what is going on in her body during pregnancy? What are all the changes? So I'm going to show you a YouTube video if I can get this to work.
Hello, in this video, we're going to talk about the physiological changes that occurs throughout pregnancy. First, we will talk about the hormones in pregnancy. So here we have a pregnant lady, and the pregnant lady has a fetus growing inside the uterus. And here we are actually having a larger picture of the uterus, and we are looking at the right fallopian tube and the right ovary. The hormones in pregnancy are very important for many reasons. One is it helps maintain pregnancy. Two, it helps prepare for delivery, for the fetus to leave the uterus. And third, it helps prepare the mother for what happens after giving birth. That is, prepares the mother for breastfeeding. Pregnancy is about 9 months in duration. We are looking at hormone concentration on the y-axis. There are 3 important hormones in pregnancy that I will draw on this graph. The first is beta-HCG. Beta-HCG is the hormone of pregnancy. If this is high, it indicates pregnancy. Beta-HCG peaks just before 3 months and then slowly goes down. Beta-HCG is produced by the placenta, essentially where the growing fetus is. The next hormone I want to talk about is estrogen. And of course, where there's estrogen, there is estrogen's mate called progesterone. Now, progesterone and estrogen are 2 important female hormones, and they are part of the normal female reproductive cycle, the menstrual cycle. However, in pregnancy, the hormones, estrogen and progesterone, the concentration actually differs, and they have a more of an important role throughout pregnancy. So let's talk about estrogen. Estrogen is produced initially by the ovaries, the corpus luteum within the ovaries, but then the placenta will take over the job. Estrogen will continuously rise throughout pregnancy. The next hormone, important hormone, is progesterone, which I mentioned. And this again is initially produced by the corpus luteum within the ovary. But then the placenta has the main role later throughout pregnancy. Progesterone rises continuously throughout pregnancy as well. However, before birth, before parturition, before the baby leaves the uterus, the estrogen and progesterone levels actually drop. And this allows for labor, it allows for birth. Throughout pregnancy, estrogen actually helps prepare the maternal body for delivery. It does this by increasing the number of oxytocin receptors in the uterus. We will look at the other functions of estrogen throughout the video. Progesterone's role in pregnancy is actually, it works as a smooth muscle relaxant, and it maintains the uterine lining. And we'll talk more about progesterone in this video. In summary, there are 3 important hormones in pregnancy to remember: estrogen, progesterone, and beta-HCG. The physiological changes in pregnancy, it relates to many things. It relates to the hormonal changes in pregnancy, the changes in anatomical structure of the uterus as it grows and fills the abdominal cavity. And it also, the physiological changes in pregnancy also relates to the growing fetus, the increase in demand for nutrients, for blood, etc. Let us look at these physiological changes by focusing on body systems. So let's begin by looking at the physiological changes in pregnancy, beginning with the respiratory system. The respiratory system is important in delivering oxygen around the body and also removing carbon dioxide, which is the waste, out from the body. In pregnancy, the uterus enlarges, and this will cause an increase in intra-abdominal pressure. As a result, there will be more of a diaphragmatic breathing in a pregnant lady. Similarly, because of this mechanism, there is hyperventilation and an increase in tidal volume during pregnancy. Cardiovascular changes in pregnancy include mainly there is an increase in cardiac output because there needs to be more flow to the placenta. The increase in cardiac output is a result of increase in heart rate and an increase in stroke volume. In the vascular system, there is a drop in resistance. There is a drop in resistance in the vessels, which actually contributes to the increase in stroke volume of the heart, and thus the increase in cardiac output. During pregnancy, there is actually a drop in blood pressure usually. If there is an increase in blood pressure in pregnancy, it is therefore most likely abnormal. An increase in blood pressure during pregnancy can be due to many things, but one thing to consider is preeclampsia. Hematological changes in pregnancy. We see an increase in plasma volume by 40%. The increase in plasma volume is actually what contributes to edema. So in pregnancy, peripheral edema is actually a normal feature because of the increase in plasma volume. The other important hematological change is there's an increase in red blood cell volume by 25%. This is important to take into consideration because the two changes we just talked about actually lead to anemia in pregnancy, which is another common finding, anemia. This happens because there is a much larger percentage increase of plasma volume compared to the increase of red blood cell volume. This means that there is a net less number of red blood cell per volume of plasma, thus causing anemia. Further, in pregnancy, there's actually an increase in clotting factors, and thus pregnancy is a hypercoagulable state. This is actually kind of dangerous thing because a common complication during pregnancy is deep vein thrombosis, and deep vein thrombosis should thus be on the radar of many health workers. The musculoskeletal changes seen in pregnancy is usually a result of the uterus growing, the uterine enlarging. As the uterus grows, there will be changes in the abdominal cavity, and this will contribute to some of the following findings. We see an increase in body mass index. Throughout pregnancy, it's normal to gain between 10 to 15 kilograms. There will be presence of stretch marks, lower back pain, lordosis. There's an increased risk of developing carpal tunnel syndrome, sciatica due to compression of the nerve around the buttock, upper thigh, and as well, muscle cramps are also a common feature in pregnancy. The endocrine changes we actually already touched on. We talked about the important hormones throughout pregnancy. However, during pregnancy, there is also an increase in anterior pituitary gland function. And so there's an increase in anterior pituitary gland hormone production and also hypertrophy of the pituitary gland. There's, of course, the pregnancy hormones, again, which we talked about, estrogen, progesterone, and beta-HCG. The other important hormone that is produced by the placenta during pregnancy is human placental lactogen. And the human placental lactogen actually has a relationship or an association with the development of gestational diabetes, a complication seen in pregnancy. The production of thyroid hormones are also increased during pregnancy. Hyperthyroidism, thyroid hyperplasia, and goiter are not uncommon features seen in pregnancy. Finally, dermatological changes in pregnancy include increased skin pigmentation, distension and proliferation of blood vessels, spider angiomata, stria gravidarum are essentially the stretch marks seen in the belly of a pregnant lady. Let's now focus on the female reproductive changes in pregnancy, and this is very important. Let us cut a cross section of the body, sagittal section, and we're looking inside the abdominal cavity where the uterus and fetus are. The gynecological changes are mainly due to the increase in estrogen, progesterone, and the growing fetus. These changes include breast enlargement, areolar pigmentation, uterine hypertrophy and stretching by up to 10 times the normal size. There is the cervical gland hypertrophy, which causes the increase in mucus secretion at the cervix and thus the development or formation of the mucus plug. And again, this is actually the result of estrogen. Estrogen also has an important role in that it actually causes the vaginal lactobacilli proliferation. These are bacteria found in the vagina, and the proliferation of the lactobacilli actually causes an increase in lactic acid in the area and thus decreases the pH of the vagina. The lactobacilli are thus, you can think of as being protective or protectors of the vagina canal and protectors of the uterus. And this is because they create an environment which is unfavorable for other pathogenic bacteria and microorganisms. The breast changes in pregnancy are very important because it prepares the breast for breastfeeding. What happens is that estrogen will cause increase in adipose tissue in the breast tissue, making the breast more large. Estrogen also causes the lactiferous duct system of the breast to form, to proliferate, and to arrange itself ready for breastfeeding. The other hormone, progesterone, actually causes the breast lobules to enlarge. Zooming into the breast lobules, these lobules contain cells which actually produce the milk. And these milk will get secreted into the lobule lumen. The lobule itself is surrounded by myoepithelium. The myoepithelium is what is responsible for contracting and thus injecting the milk through the lactiferous ductal system and then out. So just remember, progesterone is important for the breast lobules formation, and estrogen is important for the breast ductal system, so the lactiferous ductal system. It's important to remember this because it also relates to breast cancer. The urological changes seen in pregnancy. The main one is that we see a renal blood flow increase by up to 40%. And this correlates with the increase in cardiac output. When there is an increase in renal blood flow, this also means there's an increase in the glomerular filtration rate. And thus, because there's an increase in glomerular filtration rate, there'll be more urinary frequency. So there'll be more frequent urination. The kidneys also become enlarged to compensate for this increase in renal blood flow. The ureter also dilates because of the smooth muscle relaxing effects of progesterone. In the gastrointestinal system, there are many changes. The main ones is the esophageal sphincter relaxation, and this contributes to the reflux seen in pregnancy. This again is actually caused by the smooth muscle relaxing effect of progesterone. Remember that the uterus is also growing in the abdomen, the abdominal cavity. This will cause an increase in intra-abdominal pressure, which actually also contributes to the reflux. The increase in intra-abdominal pressure also contributes to the formation of hemorrhoids in pregnancy. Finally, in pregnancy, there is also reduced bowel motions, meaning constipation. And this again is a result of the effects of progesterone, which acts as a smooth muscle relaxant. That concludes this video on the physiological changes seen in pregnancy. I hope you enjoyed it. Thank you for watching.
New Woolworths lower shelf prices are being added all the time so you can continue to lower the cost of your shop. Like Rexona 48-hour antiperspirant deodorant.
That's right. Right. So you don't need to remember all of that now, but I thought it would be really good foundation for you to have. Some of you will be starting to think why are these things happening in pregnancy, and it helps you understand what's going on in a woman's body and why she might have some of these normal pregnancy challenges or higher risk conditions developing in pregnancy. And you always want to have that in the back of your mind when you're taking a history, when Sarah comes to see you and she sits down and you're starting to question all the different body systems, what might be going on and what's happening. So it's also important that you're able to differentiate between, is this just normal pregnancy or is this a red flag for something I need to give more attention to? So higher risk pregnancy conditions could be split into pre-existing maternal conditions, something that she already has going on before she was pregnant, or she might have had a previous pregnancy history that's put her at higher risk this pregnancy, or she might develop something as pregnancy goes on. So around the desks now, there are some higher risk pregnancy conditions. Now, I want you to split into pairs and just take it, it's like speed dating. Take about 5 minutes to look up in pairs one of these things. So find a buddy. We need to spread them out because some of the tables have more than others. And then you're going to report back. And what I want you to consider is a brief definition of what that condition is. Why it's considered high risk. Some of the risk factors for what you need to look out for, red flags, and then management options. So who needs some more cards? We have lots of cards.
Me neither. What is that?
I don't know.
Are we just choosing one?
Yes.
Are we choosing one?
Just choose one. Yeah. Have another one.
I like advanced midwives.
How many cards? Yeah.
Like,
I've got through enough cards.
Yeah.
Do you want to guys get to do one each? Is that all right? Or do two between you?
Yeah, no, we can do it.
I'll put this in.
Hey, I'm just saying.
Brief definition.
When in doubt, chat it out.
So hypoglycemia.
It significantly increases the risk.
Another card.
So it's
That higher risk pregnancy conditions, so just to give
the risk factors.
so high risk things to look out for. I'm guessing just 5 minutes, so it's not a big in-depth thing.
Family history. What's another word for it? Previously
Doing the presented or it's just yeah, history.
previous one.
What
about
existing conditions?
That's what someone What's that? Oh, yeah. Management.
The definition, so those are.
Does that like,
Yeah, the same thing.
red flags, management, and you can't, like, congenital.
Well, why high risk? We can increase risk of being preeclampsia.
They should get a miscarriage.
It's just like first child, like there's a great risk of like imagine being older in your first pregnancy, you pull out my mom's first pregnancy was at 29 and 363 days. Oh, high risk. My brother's 2 days. This is why it's this one makes me I think red flags, although they're just like lower abdomen. So structural pain. Weight loss, I guess it's
Oh yeah, she said we were going to take a history.
Why not? Because
They push it up, you know, just.
you go to the first one.
and then also
Yeah, something like motivational speech, right?
no, you're fine.
Okay, 1 more minute.
Is that actually?
And I guess like lots of
It's like
no, it goes back to
Start and support ginger and acupressure.
50% of people
Help my places that are rarely
just like
so you can temporarily stop or orientate to reset the system. Another mechanism of ginger is a medication.
20, bro.
I just got a definition.
20, bro.
Probably just do because you're feeling nauseous already doesn't mean this kind of problem. force it to shut down. Shut down it. And then just restart the system.
Was it sleep apnea you said?
He might die.
Essentially, that's. Oh, it was just change its line. So just like us. Start.
Hey, how you going?
Starting your brain after break that.
Yeah. So there's a collection. There's a ton of lights.
Yeah, so we should be taking medical.
You're ready to report back? I know you could go on and on, but this is just to give you a brief overview. And obviously this is not an exhaustive list. It's just a few common things that might fall up under each category. So who's got pre-existing diabetes? Yeah. And how come that might be considered high risk in pregnancy?
I mean, we already know that in pregnancy, it increases insulin resistance anyways, but if you have pre-existing diabetes, it kind of just doubles, I guess. And so maybe what was working before isn't working now. And obviously, like, it's different to gestational diabetes because it's early. So it could cause like birth defects or things like that.
Yes. And how might you manage? Get to the management question? No, that's okay. It would be similar, like you'd be wanting to keep an eye on your blood sugars as usual and then respond according to how they might be impacted by the pregnancy. So well done. Excellent. Who had pre-existing hypothyroidism? Yeah.
Yeah, so in early pregnancy, the fetus relies on maternal thyroxine. So the low thyroid hormone leads to impaired neurodevelopment. Hence, hypothyroidism can lead to miscarriage, preterm birth, preeclampsia, and placenta abruption.
Yep.
And the mother may experience fatigue, anemia, and increased cardiovascular strain.
Yes, beautiful. And did you get to management?
Yeah. The levothyroxine.
Yes.
And monitor TSH.
Yep.
TSH. Aim for TSH less than 2.5.
Yeah, I've had quite a few clients who've had pre-existing hypothyroidism and they're often on thyroxine and just sometimes need to increase it more in pregnancy and go on to have, oh, what's going on here? A perfectly normal pregnancy. So yeah, it's just something to be aware of and keep an eye on. Thank you, that's great. What about pre-existing or obesity, high BMI? Who had that?
Oh, we had that one.
Yeah. Why is that considered higher risk in pregnancy?
Well, it can increase the risk factors for like gestational diabetes, preeclampsia, stillbirth, and cesarean as well. Generally, they said to use lifestyle changes to manage the weight and just manage the BMI overall.
Baby can be more at risk for obesity.
Yes, and diabetes and some of the chronic, yeah. There's a really great resource. So Sarah Wickham is a doctor of midwifery research in the UK and she's just released a book called Plus Size Pregnancy. There's a lot of stigma around obesity and high BMI in pregnancy and a lot of outdated information around that, and her book is the latest high-level research around. So I really encourage you, if you're working in this area, check out Plus Size Pregnancy. It might change some of your approach because women who have higher BMIs, high BMI is often associated with or assumed that you're going to have some of these adverse outcomes, but it's not necessarily the right correlation. It's worth checking out. So, thank you. Okay, who had genital HPV, human papillomavirus? Yes. Yeah. Why is that a risk in pregnancy or makes it higher risk?
Well, it can transfer. Well, it's unlikely to transfer to the infant, but it can cause
juvenile onset recurrent respiratory papillary rhetosis or jaw.
Good job. Yep.
But also it can cause adverse pregnancy effects, like it can cause premature rupture of membranes, a miscarriage, low birth weight, and preterm birth.
Yep.
And it can obviously, like in the mum, because doctors often don't treat, they wait until after pregnancy to treat warts and all that, so it can cause the progression of cancer, infections, and transmission.
Yeah, thank you. So actually, if you've ever had it in the past, that's something that I would pick up in the history. And we often do prophylactic treatment. We would prescribe acyclovir at about 36 weeks pregnant, because if you have an outbreak just before birth, the babies can pick it up from being born and touching that skin in that area. And so we're trying to prevent that. So that's one of the other management options for that. Yeah. Great, thank you. Okay, who had advanced maternal age? Yeah. Why is that considered? What is advanced maternal age? Did you get a definition?
35 years or older.
Older than 35. Yep.
Yeah. And so what happens is the quality of your eggs decline as you age, and it increases the risk of like chromosomal abnormalities. It also increases your risk of having like high blood pressure, preeclampsia, miscarriage or stillbirth, gestational diabetes, requiring a C-section, premature birth or low birth weight, or again, genetic disorders of the baby.
Mm-hmm. Yeah. And can it be managed?
Kind of, not really. Like you can do congenital screening, and then generally you'll have more frequent ultrasounds. You will test for gestational diabetes earlier, and you'll have more regular monitoring for preeclampsia.
Yeah, and possibly an induction as well. So I have a colleague in Melbourne at the moment who's a privately practicing midwife, and she just put on our midwives chat that she's got a client who is 54, having a baby. It was an IVF pregnancy, but she's a fit, healthy yoga teacher. And they're just going through the process right now of deciding, do they wait for spontaneous labour or do they induce her? So there you go. Some of these things challenge some of our preconceptions. Okay, who had pre-existing anxiety and depression?
We did. I kind of got it's really
It's a big
interesting.
topic.
Yeah,
Yeah.
really interesting paper. I thought it was just like sleep exhaustion, keep postpartum, but no. So they're independent risk factors for really poor outcomes as it is.
Mm-hmm.
And it's because of a close relationship between the neurochemistry and the mechanism of placentation. So I don't fully understand it. I'm reading it now, but basically if you've got issues with your central nervous system, that overlaps with the placenta development. So you've got a risk of miscarriage, fetal growth restriction, preterm birth, low birth weights. There was something about schizophrenia and folate. So you have a higher rate of spina bifida in schizophrenic mothers. And then, of course, with anxiety, you're much more likely to have a cesarean section because the fear becomes insurmountable. But yeah, it's actually really interesting.
Yeah, it's a big topic. But, you know, when I'm doing a booking in, probably nearly everyone admits at some point to having had some level of anxiety. And so I often try and normalize, you know, to be anxious is to be human. It's our inbuilt safety mechanism. And it's about recognizing the hormones of pregnancy can certainly exacerbate or increase some of these mood disorders, or some women might just suddenly go off their medication because they're worried about the impact on the unborn baby. And so you're juggling and managing that as well at the same time. So it's just something to be aware of, and yeah, put support in place or keep an eye on. Once again, stand by. What about someone who might be smoking or vaping? Who had smoking?
We had smoking, but we didn't do it because we had
No worries.
people, so
That's
we all did
fine.
the same one.
We'll come back to that anyway because we're going to look at motivational interviewing. So thank you. Okay, what about previous pregnancy history? Who had preterm birth?
I've got it.
Yep.
So basically it's defined as previous pregnancy, which was before 37 weeks of completed gestation.
Is a preterm birth? Yep.
It doesn't automatically mean that it will happen again, but it does mean that you need to monitor the individual closely and have proactive care. it increases the risk of morbidity and mortality. And does also increase the risk of subsequent preterm births as well. And some risk factors are like smoking, alcohol, short cervix, or infections. So it's important to, I guess, monitor frequent and intimate visits and cervical length scans as well. And then some red flags may be pelvic pressure, feeling the baby's pushing down, lower back pain, or just regular uterine tightening of contractions.
Yeah, that's great. Do you know what viability is defined as? A viable pregnant, like if a baby's born early, when is it considered viable to survive?
23 weeks.
Yeah. And technically it's past 20 weeks, but most, like you're talking 22, 23 is pretty early, but babies can survive. Not always. But in Launceston, we don't have neonatologists here. We have paediatricians, but not neonatologists who specialise in preterm babies. So we can really only handle babies from about 30 weeks here. So any births prior to that or early labours would get flown to Melbourne or Hobart. All right, who had previous stillbirth?
That was me.
Yeah.
Defined as fetal death after 20 weeks. The recurrence risk is 2 to 10 times higher than what your baseline is, which is pretty, substantial. Underlying causes could be like placental insufficiency, any type of infection, genetic predisposition, or it could be entirely idiopathic and there's just
we don't know.
No reason. Red flags, preeclampsia, diabetes, autoimmune disease, there's a fair few. Central dysfunction's a big one. And then management, apparently low dose aspirin is used, and then just increased monitoring, more ultrasounds, more scans, and review the cause if it's happened before and optimize the maternal health. Mother before,
Another red flag, which will often come up in appointments, is reduced fetal movement. So we're always encouraging women to tune in to what's normal for their baby in terms of movements, time of day patterns, or over movement. Like that's another red flag. If the baby's just going nuts because it's not doing very well, that also is a red flag, and we would encourage women to come in and get checked. Thank you. We had twins or triplets. Yeah.
So to define it, I suppose you have two or more fetuses in the uterus. Why it's considered high risk is because you're at high risk of complications in pregnancy, so like gestational diabetes, preeclampsia. There's a few different ones like fetal growth restriction or abruption of the placenta, particularly if you have 2 placentas going. So that's also risk factors. Risk factors are having had multiples before. Can just be associated with your genetics too. And then what's the other one? Management?
Is it managed any differently to?
Not really, it's just followed closer. You might have a different birth planning. You might, twins can be delivered vaginally if one of them's facing head first, but typically triplets would just be a section. And otherwise, like a particular diet, increasing folate, iron intake, sort of thing.
Yeah, great, thank you. Previous gestational diabetes.
So it's just insulin resistance picked up or induced by pregnancy because the placenta releases hormones like human placental lactogen, cortisol, and progesterone, which increase that insulin resistance. It's high risk because I think it was 30 to 80%. You have a higher recurrence risk in next pregnancy of getting gestational diabetes, as well as I think it can lead to a chronic insulin resistance, which could cause type 2 diabetes down the track.
Well done for picking that up. That's often missed. So
And then thank you. And then management is just, I think insulin is good because it doesn't cross the placenta. And then just normal lifestyle stuff. Try to get them to do some kind of light activity, and then metformin as well, I think.
They're different. Like you can have injected insulin, or you can have the tablets, which is the metformin. A lot of my women have who have early signs of gestational diabetes, we can manage with diet and exercise. So that's a great first start. I always say no naked carbs. So you don't want to eat any carbs without protein with it. That reduces your insulin spike. A really great Instagram page to follow is Glucose Goddess. She has a whole heap of little graphs showing the order you eat foods and what you combine them with and how it spikes your sugars or not.
She's the one that wears the really fun.
Yes, she's French. Yeah. The Glucose Goddess is a really great resource, and I find women, I mean, I have books that I can lend out, but a lot of women prefer to just look on the Instagram and yeah. Great, thank you. All right. So conditions during pregnancy, who had hyperemesis?
Yeah, we got it.
Yes.
So it's like a severe form of nausea and vomiting in pregnancy.
Yeah.
And I guess why it's high risk is that it can cause like severe electrolyte imbalances or esophageal tears.
Yeah.
And there's increased risk of a preterm birth.
Yeah.
It also has like psychological impacts with depression, anxiety, PTSD. So for risk factors, there's I guess a previous pregnancy with I guess multiple children, like triplets, gestational diabetes, and family history of hyperemesis gravidarum. There's some red flags like dark urine, ketone breath, and hematemesis.
Yeah.
And yeah, I guess neurological symptoms such as extreme dizziness, confusion, or blurred vision. And management, we can use IV hydration,
yeah.
use vitamin supplementation, and yeah. There's also like this weird, I guess, nutritional support. You can do like a complete gut reset, and you can use ginger or acupressure.
Yeah, so hyperemesis is a lot more than just nausea and vomiting. It's very serious. Like women often lose weight, they can miscarry because of it. It's persistent vomiting. It's miserable. And they've recently discovered that it's linked to this, it's called the GDF15, and it's a protein hormone released by the fetus. And women who are particularly sensitive to that seem to be the ones that end up with hyperemesis. So it is a genetic thing. Often they need lots of antiemetics, lots of admissions to hospital for IV fluids. Yeah, it is a high risk pregnancy. Yeah. Who else had another gestational diabetes? Did anyone else do that?
Yeah,
yeah.
It develops.
Yeah.
Not a lot to add to
yeah.
Jack's diligence, but I suppose high risk. It's high risk because there's many maternal and baby complications.
Yeah.
One of which is macrosomia. So
yes, thank you for mentioning that. Yeah.
Size.
Do you know why do babies end up bigger if a mum has gestational diabetes?
In particular, no, but presumably it's a metabolic growth, lots of sugar available.
That's right, not enough insulin to get the sugar out of the maternal blood, and so that passes into the baby and grows a fatty boomsticks baby. Yeah, baby on junk food. Yeah, keep going. That's great, thank you.
The macrosomia can increase the risk of C-section or increase the need for C-section. Otherwise, I think.
Yeah, there is crossover, but thank you. That's great. All right, hurry up to preeclampsia or HELLP syndrome.
We have that. So preeclampsia is a placental disease which causes new onset hypertension in about 20 weeks gestation.
So it's high risk because it can lead to damage to the mother's organs.
Yeah.
So particularly the kidneys. I guess risk factors, if it's the woman's first pregnancy, if she's had multiple pregnancies, if she's got a history of hypertension, if she has diabetes or previous kidney disease, if she has a high BMI, or if she is under the age of 20 or over 35.
In terms of treatment, the main thing is you want to get the placenta out, so giving birth really. In the meantime, blood pressure medication, beta blockers, that sort of thing can help.
And they'll often give a mag sulf infusion as well to help
Offers seizures.
Yeah, exactly. HELP syndrome stands for hemolysis and elevated liver enzymes and low platelets. So that's what happens when this high blood pressure goes unmanaged. And I looked up why, and it's, if you imagine like high blood pressure vasoconstriction and the red blood cells are being forced through a really tiny pipe and they get banged up and they break up and that causes the hemolysis and problems. So yeah, it's very serious. And the signs that you would look out for, women can get headaches, visual disturbances, edema, protein in the urine, high blood pressure, all of those, that kind of gives you a picture of, okay, what's going on here. Yeah, thanks. I skipped one, but who had gestational hypertension? Or it gets to eclampsia and HELP syndrome. Yeah.
Basically, it's just getting high blood pressure after 20 weeks of pregnancy without previous like chronic hypertension or preeclampsia symptoms. It typically resolves within 12 weeks after like postpartum.
Yep.
It can increase the risk of future cardiovascular issues, and generally it's asymptomatic and it's normally discovered during like routine checks. I think normally for management, you just do frequent monitoring because it's self-resolving. But if not, for severe cases, you give antihypertensives.
Exactly, yeah. And so it would be diagnosed as anything over a 140 or 90. Have you guys been doing blood pressures? Yeah, I don't know what you've done. I'm sorry. So just let me know. You know a normal blood pressure, you're familiar with that. So, and obviously in pregnancy, blood pressure is often lower. So by the time you get to 140 or 90, that's considered significant. All right, where are we up to? Fetal growth restriction or IUGR? Yeah.
So fetal growth restriction is basically when the baby is smaller for their gestational age, usually due to placental insufficiency.
Yeah.
And so the reason why it's considered high risk is because it can result in stillbirth, fetal hypoxia, preterm birth, and even if the baby is born, you would get neonatal complications and like long-term complications like neurodevelopmental delay. Yeah. Some risk factors, as I said before, the main one is placental insufficiency, but you can also have a lot of maternal risk factors as well. So things like smoking, alcohol, chronic disease like hypertension, preeclampsia, like what's written up there. Red flags, obviously, if you have a small baby. And other ones would be if you had an abnormal Doppler, so like the
blood flow.
the blood flow. And if you had a very low amount of amniotic fluid, which would indicate something wrong with the placenta. And last one is management. So we would want to confirm the diagnosis using the ultrasound growth scans and the Doppler studies. We would continue to continue surveillance and treat the underlying cause, because it doesn't help if the mother is still smoking or has hypertension. And yeah.
Great. And IUGR stands for intrauterine growth restriction. Who had anemia?
Yeah, that was us. So this is anemia. I think it's more common towards the later stages of pregnancy, so second and third trimester, and it's mostly due to not meeting the increased iron requirements that of the growing fetus, but also the expansion of the maternal red blood cells and the blood volume. Considered high risk, obviously due to those classic anemia symptoms on the mother, but also links to premature birth and other things like that. Red flags, sort of things like your classic symptoms like pallor, you can get tachycardia and stuff from hypoxia, and then also syncope, the risk of that. Yes, and then management, sort of with supplementation, so antenatal supplements, transfusions, depending on how low the hemoglobin is, or oral supplementation as well.
Yeah, it's really common. I send lots of my women off for iron infusions, and none of them have ever regretted it. It's hard when you're anemic in pregnancy to get your iron up just with supplements because the baby's taking so much. So often iron infusions work really well in pregnancy. Yeah, thank you. Who had cholestasis?
Oh, that was us.
Yeah.
It's pregnancy-specific liver condition causing impaired bile flow. Typically in the third trimester, usually presents with itchy hands and feet without a rash.
Yes.
And maybe some mild jaundice, but less commonly. Not really well known how it causes it, but mostly estrogen and progesterone that they're thought in impaired bile flow. There's not really many maternal risks. Symptoms usually resolve after delivery, but for the fetus can cause preterm birth, fetal distress, and if you have really high bile salts, you can have stillbirth risk.
Yeah.
So it's just managed with ursodeoxycholic acid, which
well
improves symptoms. And then just symptomatic relief for the itchiness, so just antihistamines and topical agents. And then if it's really high, maybe a little bit early delivery, like around 36 weeks or so.
And it often only shows up around then anyway. So yeah, great, thank you. Couple more to go. Placenta previa. Yeah.
So placenta previa is when the placenta covers the cervix.
Yes.
And it's high risk because you might get severe bleeding and preterm birth. Some symptoms are painless and frequent bleeding, and also reduced movement of the fetus. Red flags. Risk factors are previous pregnancies, multiple gestation, or when the mother is over 35, smoking or cocaine use, and management is basically cesarean.
Yeah, so often that will get picked up at 20 weeks on the morphology scan, and we'll talk about scans in a sec. Every time you have a pregnancy, your placenta will implant on a different spot in the uterus. It never picks the same spot twice. So the more pregnancies you've had, the higher chance that it's going to implant over the cervix, which is the opening of the uterus. And obviously a baby can't come out the opening if the placenta's in the way, or the placenta will come first and then the baby has almost no time because no oxygen supply to get out. But actually 90% of placentas who are covering the cervix at morphology at 20 weeks will move out of the way by the time a woman is full term. But you're right, if it hasn't moved, it has to be a cesarean birth. Yeah. Placenta eruption.
Yeah, that was me.
Yeah.
And that's where the placenta separates from the uterine wall before birth, either partially or fully.
Yes.
And obviously that's bad for the baby and the mum because the placenta is the source of nutrients for the baby. So if that's no longer attached to mum, then the baby's not getting nutrients. And it's also bad paternally because it bleeds and all the risks that come with big hemorrhage and bleed from that. Risk factors, you can have a previous abruption, preeclampsia, and like lifestyle things as well. So cigarette smoking, cocaine or amphetamine use, trauma to that in general. And then you notice it with sudden severe abdominal or lower back pain, vaginal bleeding as well.
Yeah.
And management, I think, depends on how the eruption is and how far along.
Yeah.
So if it's really bad, I think it's immediate birth.
Yes. Emergency cesarean. Yeah. Yeah. Thank you.
Can be managed conservatively. It's not that bad.
Thank you. Very scary, and hopefully you never see it. Polyhydramnios, last one. Who had that? Yes.
So it's essentially excess accumulation of amniotic fluid.
Yes.
And so it causes like over distension of the uterus. So that can lead to premature labor, pre-labor rupture of the membrane, umbilical cord prolapse or placental abruption. And so having gestational diabetes, multiple gestations, or structural or genetic abnormalities, which inhibits the swallowing of the fetus, of the amniotic fluid by the fetus, increases risk. And then symptoms would include like rapid belly growth, severe belly contractions of labor pain, like that. Oh, and also reduced fetal movement. And then management includes amnio reproduction, which is like using the needle to
take some out.
Take it out. And then we have indomethacin, which is like NSAID, which reduces fetal urine output, and then which reduces amniotic fluid, and then treat underlying causes. And early delivery.
Yes, and early delivery. Yeah. I had a client once who I measured her belly, and then the next appointment a couple of weeks later, it was significantly bigger, and she had developed polyhydramnios, and it turns out her baby had a really severe syndrome. It wasn't compatible with life, and yeah, very sad, but it was very obvious as well. But that's not always. Some babies are just fine. There's just a lot of fluid. Okay, so you got an idea of some higher risk pregnancies, things that you want to look out for when you're taking a history. So have you guys done general history taking without the obstetric component? I figured you had, so I won't spend too long on that. Do you have some sort of template that you follow in your head when you're taking a history? Yeah. So just keep that, but this will just be some extra on top of that. And I would just say with a pregnant woman, it's really important, like with any patient, you want to connect and build a rapport with her. So just being aware, once again, she's a human, not just a condition. She's not just pregnancy. She's Sarah, or she's whoever she is. And be careful of your language. Like, you're not going to just jump in and assume congratulations when she comes to you pregnant. This may be not a planned pregnancy. She may be deciding how she wants to progress or not with this pregnancy. So just be a bit sensitive about the language that you're using. So we're just going to work our way through fairly quickly, like a history. So obviously your general demographics. I assume most of you will be working in places where there's been an admin staff that's taken most of these details. I'm taking them myself when I'm seeing someone, so that's why I just included it today. But current pregnancy, I always start with current pregnancy. That's what she's come to you with. So I'm asking EDB, estimated date of birth, whatever she thinks that might be. She might not know. Last menstrual period. Has she had any early scans? Probably not. That's probably why she's coming to you to order all those things. So I'd be asking about her cycle. How long's her menstruation? How long between periods? Is it regular, irregular? And then once again, was this conception a planned conception, spontaneous, unplanned? Was it IVF? They're all important early parts of history taking. Was she breastfeeding or using contraception when she fell pregnant? And then you're going to ask about any previous pregnancy she may have had, which includes any miscarriages, terminations, non-viable, which might be an ectopic or a molar pregnancy. Has she had any D&Cs for miscarriages or terminations, dilation and curettes? And if she said she's had previous pregnancies, don't assume she has children or that she has the children with her. Just be, once again, sensitive to language. And I do want to really emphasise, because this is the midwife in me, please don't use the word delivery. It's a previous birth. So in my world, pizzas are delivered and babies are born. So I think the word delivery is it's a very medical word, and it's used commonly in obstetrics and midwifery. And it came from the idea that I showed up and saved you and I delivered you with your baby. But that's quite disempowering language. Actually, women birth their babies in their own power, and we stand by and help when needed, but she gets the honour of having birthed her baby, even if it's a caesarean birth. So try and get familiar with using the word birth instead of delivery. So yeah, find out, has she had any term or preterm births, live births versus stillbirths, normal vaginal births, was it an instrumental like a ventouse? We'll cover all of that next time. A LUSC is a lower uterine section, caesarean section. What date were those births? These are all the things I ask. How many weeks gestation when she had that baby? Were there any antenatal complications? How long was the labour? Were there any complications in the labour? Any genital tract trauma? Did she need stitches? Third stage, so that's referring to the placental birth. How did that go? What was the estimated blood loss? Like, did she have a postpartum hemorrhage, or was it just normal? If she knows, she may or may not know, and that's why I would also always request previous history from wherever she had those babies where possible. Name, sex and weight of previous babies and how she fed them, what she plans to do with feeding the baby this time. Does she have good support? I need to say earlier on, this is all being recorded, and I'll send through my slides for you so you can have access and revisit them later on if that's helpful. So I just want to stop here and look at like obstetrics and midwifery. This whole area is a whole nother language, like all of medicine. We have our abbreviations in all our areas. So I just want to go through a few of them for you. So have you heard of gravida and para? Often when we're writing notes, we might say someone is a G1P0. So gravida refers to the total number of confirmed pregnancies in the past, regardless of how far they went. So if she got a positive pregnancy test, that's a gravida. number, so you add that on. Para is how many pregnancies got to viability, which remember is after 20 weeks. And then sometimes you'll see someone attach an L, like a GPL. L is how many living children. Apparently that's not done in Hobart, but I've seen that done quite a bit here. So it's going to differ from area to area. And T can stand for termination, E for ectopic, and M for miscarriage. So a few examples, like got a G3, how many pregnancies has she had? 3 pregnancies, and a P1, what does that mean?
One reached.
One reached viability, like past 20 weeks, but L is 0. So what does that suggest? Yeah, stillbirth or it was a stillbirth. Or the baby died maybe early, after birth. But more commonly, you'll just see something like G2P2. She had 2 pregnancies and she had 2 that reached viability. And if there's no L after it, you can kind of assume that they were living babies. You might see something like this, G3P2. So she had 3 pregnancies. She's got 2 babies plus 1 because she had twins for that one. So gestation is written out of 40 weeks. Pregnancy is considered 40 weeks. A normal full-term pregnancy is anything from 37 to 42 weeks. We seem to think 40 weeks is the cutoff. In my world, normal is right up to 42 weeks. After 42 weeks is considered post-dates. But at the LGH, they like you to have had your baby by about 10 days past the 40-week mark. So they're often starting to induce you around that point because they want the baby well and truly out by 42 weeks here. So they'll write it in terms of how many weeks plus how many days. So 41 weeks and 5 days. So you'll often see something like that written in notes. And then just I never hear the word nullipara or nullup used, but what that refers to is never given birth. You'll hear primip or multi are the most common use. Actually, primip means you've given birth once or you're giving birth for the first time. But in practice, anytime you hear primip, it's usually just referring to someone in their first pregnancy, actually. And then a multi is someone who's given birth more than once in practice. Here they say you have to have given birth 2 or more times is the official definition, but in practice, if someone's had 1 baby already and they're pregnant again, we call them a multi. Some people document things TPAL, any term, preterm abortion, living. You'll work out your own abbreviations based on the area you work in and what's normal in that culture. EDB, estimated date of birth. You'll sometimes see EDD. That's the old way. Once again, estimated date of delivery, but we want to swap it over to birth. So EDB is better to use. LMP is your last menstrual period. EBL is estimated blood loss. NVB, normal vaginal birth, and that could still be with instruments. If it's come out the vagina, it's considered an normal vaginal birth, NVB. LUSCs, I already said. If it's got an EM at the beginning of it, it's just referring to an emergency cesarean. It doesn't mean it was an emergency. It means it was unplanned. So if a woman was in labour and then something changed and she ended up having a cesarean birth, it's always recorded as an EM LUSC, but it's actually, it should be called unplanned rather than emergency in terms of a woman's perspective and the story she carries with her. But anyway. IOL is induction of labour. ROM is rupture of membranes. And PROM is prolonged rupture of membranes, or there's PPROM, which is preterm rupture of membrane. So there'll be more abbreviations coming up, but these are the main ones when you're taking a history that might pop up. Any questions on those? Okay, so then you want a gynae history. So we've done general, current, obstetric, gynae. Just try and always use everyday language. Try not to use those abbreviations when you're speaking with women or their partners. It becomes second nature when you're in that area, but it's not for them. It just feels like, well, too much. So you want to ask about any cervical screening. So she might know that as a pap smear. It's called cervical screening now, not a pap smear, but that's probably what she'll know it as. And you just want to know how long ago did she have one. She probably won't know the exact date. I just ask for a rough year. Was it roughly was it 10 years ago? Like, are we due, or did you just have one last year? Any abnormal results, any treatment for abnormal results with cervical screening, any sexually transmitted infections in the past or currently, polycystic ovarian syndrome or endometriosis, because that can impact fertility and even just how the pregnancy goes. Yeah, once again, menstruation questions or contraception if you haven't asked that already. And then I assume these last ones are kind of would form part of your normal history taking, right? So just some things I want to highlight in terms of surgical questions. Like we always like to ask about how they've reacted. Have they had anaesthetic? Have they had any reactions to anaesthetic? Have they had any surgery on relevant body parts to pregnancy or breastfeeding? So uterus, genital tract, breast, abdominal, pelvic surgery, any laparoscopies, because they might have adhesions from some of those from scar tissue, appendectomies, renal stones, all of those sorts of questions. Any breast implants or reductions or other surgery on breasts, or spinal or pelvic surgery, which might affect labour and birth, scoliosis, fractures, any plates or tumours. And then medical history. So you'll have your process for this. I've just kind of listed all the areas that I would go through, like all the body systems, all the questions that I would ask. And I'm going to show you my templates in a minute. And then that includes mental health, any mental health conditions. How was that managed? What's her current mood like? And then, have you heard of the Edinburgh Postnatal Depression Scale? It's called the EPDS for short. It was designed as a postnatal depression little questionnaire to help a practitioner assess how a woman was managing postnatally. But we actually offer it to all women during pregnancy now to get a baseline, and sometimes because pregnancy can already affect a woman's mood and she might not feel like herself. And it comes up with a score. I'll show you what that looks like in a minute. And there's a really great website in Australia called Cope, and that is really, it has stuff for women on it and a lot of resources to support them with mental health challenges. But for practitioners, it has the EPDS and a lot of online screening tools that you can access. So a lot of practices will use those resources from Cope. And then I also want to know, is she on any medications? Is she taking any supplements? Does she smoke, vape, use drugs, drink alcohol? Any alcohol in pregnancy harms the unborn baby. Because babies, like, they drink the amniotic fluid and pee it out. So they're just constantly getting that alcohol recycling through them. It's fetal alcohol syndrome. So we're really trying to encourage women not to have any drinks of alcohol when they're pregnant. Any allergies? And then we often ask, have you previously received a blood product? That should say product, not produce. Goodness. In the event of emergency, would you accept a blood product or a blood transfusion? That's important. You would always ask a woman, obviously, but if she was unconscious, you would ask her next of kin. But some groups, like Jehovah's Witnesses, will not accept a blood product even to save their life. And so it's helpful to have known that in advance and have that documented. Okay, so I don't know if you can see very well actually, but if you look at the slide, this is my template. So I was using paper-based for a long time, and so I would have paper files. And so I start off with all her details, previous pregnancies and previous history, and I go through antenatal history, gynae history. Does she need assistance with hearing, vision, speech, mobility, literacy? I just tick anything that's relevant. Any oral health, surgical history, complications with anaesthetics, infectious diseases. I just list them all for her and she can let me know if she's had any of them. Autoimmune disease, metabolic, immunocompromised, any cancer, cardiac disease, endocrine disease, and I'd list a few of these because a lot of women won't know, well, what's endocrine disease? I'll say, what about diabetes or thyroid issues or polycystic ovaries, gastrointestinal or liver disease, blood disease, being anemic. That's those questions about blood products. Musculoskeletal, kidney, renal, urogenital history, neurological, mental health. If you have had any treatment for any of those things, respiratory, allergies, and then a few family history questions, any biological, your biological father of the baby, or anyone like first relative, any history of those things, medications, alcohol, drugs. And then this is more the psychosocial. This is the Edinburgh scale. And I've written the scorings on here so you can see, but you just hand this to a woman and ask her to tick which one seems most relevant. You're talking about in the last 7 days of being able to laugh and see the funny side of things as much as usual. And she'll just tick which one. And then you add it all up and you get a total score. And then also they want to know a score for question 10, which is having thoughts of harming yourself. And that gives you an idea of if she might need some extra support immediately. Psychosocial is just looking at family support that she might have and more mood type questions. And then domestic violence screening. So there's a little blurb, and if you work at the LGH, I reckon it's very similar to this, that we ask all women these questions. We want to support you. And have you been hit or slapped or hurt by a partner or ex-partner in the last 12 months, or frightened by a partner or an ex-partner? I've heard some histories where they say, do you ever feel frightened by anyone that comes to your home? Something like that. So just trying to give her the opportunity to confide in you if she feels she wants to at that point in time. And then down here, I would just tick any referrals that I might want to make and what model of care she's having. So I would take about an hour to do a full booking in history. I went up to the LGH last week to sit in with one of the doctors because I realised I know what it's like from a midwife's perspective, but I wanted to know what it would be like for you. You guys only have 15 minutes. So you're going to get very good at taking short, succinct histories. And this is one of the challenges in all areas of medicine, is the time factor, that, you know, you can't give every person the amount of time that you probably want to. So I'm conscious of that, and you will have your own methods and systems for history taking. But yeah, I just thought we walk through just those extra bits from an antenatal perspective, the things you want to look at. Right, go and have a 5-minute break, I reckon, because we've been going for a while. And we're going to move into some of the screening tests after we come back. And then we'll get the model out and do some playing. Where are you going now?
Information was really that I've got. I have my main surgery and he was like, oh, before we go should do we could do another alone, which is what you just. And but the issue was that I don't know if I have less than I was 14 with that. So I was like, I've had a surgery where you cut exactly where you said I've got that exact scar that I was broken. And he was like, oh, that scar's from moving from your facial. And I was like, no, because I had that in January. Because you're where my scars are.
So will he be able to get that information?
I got them to, I have to make calls, so I've set my operation report, which gives like a blurb.
Yeah.
Of my procedures. So,
So you've had 6 operations.
yes, that goes over a page. And they're missing my first one. They've only got,
Okay, so 6, yeah.
because my first surgery was a 2-stager, but they've only got 1 stage on here. Having got my surgery from the old.
That's very frustrating for you and probably for him.
Yeah, so I want to see him in person. Which I needed to anyway, but I just wanted to do the first one in case he was
Yeah, there's nothing I can do.
And he's free from the Tuesday 21st.
So is he like in Tassie, or do you have to go to
So he's free from the 21st. He works Tuesdays and Thursdays, so I'm probably going to do a day trip with my mum. We won't have placement, it'll be a learning day. And I'll just do a day trip with my mum, go and see him.
Do we have do we have like a specific learning day where you don't really have anything on?
Yeah, I was gonna say, to be honest.
Yeah, oh no, that's true.
But I could still do the 4th of June one.
Yeah. You'll just, no, because that would be the public holiday maybe. No, because that's always on a Monday. Just make sure.
说哦，我要每天签，那你就要每天给他。而且一个星期才签一次，那你就一个星期会。
去了你那个 rice 可以每天去，那每天去那就要钱。
Is that the workshop that?
也没有有几下他。
And so then we have that one, and then afterwards we've got like a bit of one.
But yeah, but I'll see what classes are scheduled.
Yeah, just as long as it's not anything that you need to get signed off. Get this ticked off.
From what?
I think there's only a couple of things on the list that we went through, like in the sense of conditions that you can develop that I didn't know. But that I think a lot of the times it's because they use like a strict word that I didn't know. Okay. I've got chocolate in my locker, so we can go grab that.
一个 useless。
然后他说 that has been missed out， 所以就是明天那个就是实体的，对，再上一遍，这就是实体的，上星期是。
真的假的？
是一模一样，就是跟我们那个。
Oh,
the red workshop 一样，就是看的 video， 然后再。
Oh yeah.
No, I thought I was back in like I'm pretty excellent.
因为他每堂课要上2遍呢。
10点到10点半不是那个 appraisal
对呀，8点半到10点就加了一课。
其实都是不同的。
也就是8点半到10點，也全部同一上啦，只有就在微信群一發睇完之後，有成日都會唔會睇咯？
Why do we need this one? Should I not count?
Wait, what is that on Wednesday? Did you see that?
Email they said that we have 8:30 class on.
When did they send this now?
Yeah, exactly 3 minutes ago. They just added the night time because it would 8:30 to 10.
You know what? I
Just tomorrow I'm gonna be I need teddy bears 2 early mornings meeting and it's like I'd be there from 8:30 to like 6 and then there's a Zoom afterwards. What is like
I didn't realize, right?
Yeah.
So,
Bro, sorry. I keep thinking I was just like what's it like what's
Oh, and she heard it.
so what's it
And then now we just like on Facebook. Honestly, real. It's just like I thought any of classes really do it.
At least we get the cats present.
Right? And then the next one, like CBL, I'm thinking Alistair has
research that changed to have 2 classes.
Oh yeah, because it wasn't there before. I only found out this morning.
Yeah, because I didn't bring anything with me.
Great.
It must have been like Friday.
At least you get.
And I'm pretty sure I made the thing on Thursday, so I don't know why. I saw you making it, something I made. You inspired me to make it.
And then we both laughed.
I regret everything. Also, what do you mean we need to make a recipe and then put it onto the?
Yeah, just give like a recipe.
It's gonna be so dodgy. So ugly.
That's fine, just make it.
这个是 clinical report 跟那个 attendance sheet 不一样。Mean we also give you an attendance sheet by something and to sign off by the team.
We've already using that.
看是他对你的表现去评分，对。
I don't mind. 这个是另一样，但是 we will also check you. So you will not.
That's what, at least gestation money. I don't know.
We just have to enter into the plan and
I actually,
you can't go wrong, especially our demographic.
That's fine.
Can't go wrong.
Finally, finally.
Such a good
I think that was one of the things.
So after we have the workshop, what was supposed to have as projects?
Yeah, I remember seeing that because I was like,
Really?
oh, yeah, but it's not short.
That'll be fine, bro, as long as we get the back.
It got, you see the other case was on it.
Mum refused to do the thing, and I think I would do the same thing. She's like, I'm not gonna do anything.
I don't know why.
Apparently, like I emailed them.
I want that one back.
It might be one of those things that she didn't necessarily do.
Actually heard
I'm not looking to spend hours on the game.
Yes, and we've definitely done it in the next class.
We're gonna do a Friday session.
It depends, I guess it comes back to woman centered too. If I have a client come to me and she wants a private spot and it's not my job to try and let somebody else first. The right thing for my life. So being woman centered is personally finding out that what is a C-section you don't have.
Monday.
Cesarean is a major abdominal surgery, so there's a lot of physiological downside. Like the babies are much more likely to develop because they don't have of the vagina to sort of that's not, so they have a lot longer recovery recover as fast as major surgery. They would be the obvious downsides. Unless there's pretty bad birth, and so she's going to do that. I think benefits of both. We find that she might change her mind. Thing she's ever done, like transitions of woman from baby to mother, it's a significantly transformative experience, and some women there are definitely pros and cons to both. I'm not thinking one way is not parity, even though I would always still say come back to what needs. She might just need some education. Not my job. I'm putting that on this task.
Oh, no, I'm not doing this at 7 a.m.
She do that, so.
Like 8 a.m. to
What's wrong with me? What am I Alrighty, we're all back. We'll keep going. We've got about an hour to go, so you're doing very well. It's hard on in the afternoon, I know. So you've taken Sarah's history now, right? Thank you. So you've taken her history, and some things might have come up for you. You might have heard that she vapes occasionally, or that she drinks alcohol occasionally, or there might be something that's jumped out at you that you want to talk to her more about. Have you guys covered motivational interviewing?
Morning.
Oh, amazing. Okay, so I can kind of skip through this then. So I want to give you an example. So I wasn't sure if you covered it or not, but I knew it was part of what you had to cover for this. So basically, common pitfalls are we think we're the expert because we're the ones that are in the position of power. She's coming to us for knowledge, skills, our experience. And sometimes that means we set ourselves above and jump straight into giving advice to her when we hear something that we don't like. Or we overload her with information. We're like, but you wouldn't make this decision if you knew da-da-da-da-da-da-da, off we go. Or we use fear-based messaging. We try and scare her into doing what the hospital policy says or what standard care or practice is. We start telling her what she should do. How many of you like being told what you should do? Not many of us like that, right? So people are more likely to change when they feel heard, respected, and in control of their decision. So our job is to give her information, yes, give her support, yes, and honour her. That's what woman-centred care is, letting her make a decision that feels right for her. So you've gone through motivational interviewing, so I can probably skip over this. But I just want, and value-based counselling, did you do that as well? Same, it's very similar. It's slightly different in motivational interviewing would be perhaps trying to help her change her behaviour or motivate her to make a different choice, like if she was smoking or drinking alcohol. Value-based counselling is more along the lines of helping her work out what feels right in terms of a screening test or something and she's like, oh, I don't know if this is right for me. It's helping her tune into what her values are. And so you're asking things that help her reflect, really. Like, so when you're offering screening, you might say, well, what matters most to you in making this decision? Like, would you continue the pregnancy or not if there was an abnormal result? Something like that. Like, you're finding out what her values are. Or what have you heard about that kind of test or that procedure? And then you might ask permission to speak about it. Would you like me to go through what we know and give you some information? See, the ball's in her court. So the goal is always informed choice, not compliance. And this is easy to say in the classroom, but when you get out in practice, there's a lot of pressure to follow hospital process, policy. And did you know it takes about 17 years for updated evidence-based information to make it into hospital policy? So sometimes your patients will come to you with more updated information than what you might not even be aware of, because hospital policy is out of date often. So just be aware of that. We're not trying to make her comply. We're there to serve her. She's employed us. Yeah. And if she says no to what you've offered or recommended, that doesn't matter. You just document. You did the right thing. You told her about the policy or recommended care, and you document what her decision was. It's not up to us to make her do what we want, right? Okay, so got just a little role play here. So I want, who do I want first? Do this one first. Okay, I want a girl to volunteer and read a script for me. Yep, thank you. Okay, so I'm going to be the doctor, and we're going to start with the not very good way of communicating. Okay. So your name is Chloe. So Chloe is 21 years old. She's a G1P0. So this is her first pregnancy. She lives an hour and a half away and she's missed multiple antenatal appointments. She smokes 10 cigarettes a day and occasionally uses cannabis. She says she's trying to cut it down. So I'm sitting down with Chloe. Chloe, so I see you're still smoking and using cannabis. You really need to stop. This is harmful to your baby.
Yeah, I know, I've been trying.
Well, you know, trying isn't enough. Smoking can actually cause growth restriction and stillbirth. You should quit immediately.
It's just been stressful.
And you know what? You also really need to attend your appointments. Missing them puts your pregnancy at risk.
It's hard to get here.
You really need to prioritize this. I'll refer you to a quick program. Okay, so that's an extreme version of what not to do, right? Like, it's me being very directive, not listening to her, not exploring why she's having challenges getting to antenatal appointments or why she might be smoking in the first place. And so she shuts down. She's not going to want to share with me at all. She feels judged. So let's try it again using motivational interviewing. Hey, Chloe, it's good to see you today. Thanks for making the trip in. How have things been going for you?
Yeah, they're going okay, just tired.
Yeah, it sounds like you have a lot going on. I was just wondering, would it be okay if we talked a bit about smoking and cannabis?
Yeah, that's fine.
So I just wondered what your experience has been with that during this pregnancy.
Well, I mean, I've cut down a bit, but I do still smoke most days.
Wow, that's amazing. Well done. So I hear that part of you've made some changes already, but it is still hard to stop completely. Is that right? Yeah. And so I was just wondering, what do you enjoy or what do you get out of smoking?
I find it really helps me to relax.
Yeah, okay. And is there anything that concerns you about continuing?
I mean, I know it's probably not great for the baby.
Well, that does sound like a really important tension. I hear like you get relief from it, but you also worry about your baby. So on a scale of 1 to 10, how ready do you feel to make any further changes?
Maybe a 5.
Yeah, okay. So why a 5 and not a 2?
Because I do want to cut down.
Okay, amazing. Well, that's a really strong place to start. What feels like a manageable next step for you?
Maybe not smoking in the mornings.
Okay, great. That sounds realistic. Would it help to talk through that or get some more support with that?
Yeah, maybe.
And I also realised getting here is a really long trip. What's been making that hard? And then we could go on and talk about that. So can you hear the difference? Like you're exploring why she's wanting to do what she's doing, what's important to her. You're keeping the door open for her to communicate with you and open up. And we'll do one more. I want a guide this time. Yeah, awesome. So you're the doctor in this one. Start with the red side. I'll go back here, up here for the sake of the recording. So this is Rachel, is 41 years old. She's also a G1P0. She's 28 weeks gestation with an uncomplicated pregnancy. She declines recommended vaccinations, which is pertussis or whooping cough and influenza, stating that she prefers to avoid unnecessary interventions and is concerned about safety.
Rachel, I see you've declined the vaccines. They're very safe and recommended. You really should have them.
Well, I'd prefer not to.
There's no evidence they cause harm. The risks of not having them are much higher.
Well, I'm just not comfortable.
Pertussis can be fatal for newborns. I strongly advise you to reconsider.
I've done my research. Obviously, that was a very black and white version of that, but I have heard that version many, many times in the hospital where someone who has a different opinion to us as healthcare providers, we're not interested or curious in where they're coming from. We just shut them down. So let's try it again using values-based counselling.
Rachel, I see you've chosen not to have the vaccine so far. I'd really like to understand your thinking. Would you be open to sharing what's led you to that decision?
Yeah, thanks. Look, I just don't like the idea of putting anything unnecessary into my body during pregnancy.
So minimising interventions and keeping things as natural as possible is really important too.
Yeah, yep, exactly.
What have you heard about these vaccines?
Well, I've heard mixed things about safety.
That makes sense. There's a lot of information out there. Would it be okay if I shared what we know and then we can see how that fits with your values?
Yeah, okay, yep.
These vaccines have been studied extensively in pregnancy. The main benefit is protecting your baby in the first few months of life when they're most vulnerable. Like anything, there are small risks, but serious side effects are very rare. Given your focus on safety and minimizing harm, how does that information sit with you?
Look, I still feel unsure. I didn't realize it helped the baby that early. Did I have a bit more on yours?
Yeah. That uncertainty is completely okay. Would you like some written information to look over? We can revisit this at your next visit.
Yeah, okay, thanks. I'd really like that. Thank you. So you can hear the difference, right? Like you're trying to be woman-centered, you're trying to find out where she's coming from, why she's coming from that position, and respecting her choice in that. So if you look at some of these other examples, you might come across someone that doesn't want any ultrasounds, or they occasionally drink alcohol in pregnancy, don't want any vaccines while pregnant at all, or they have diabetes, but they don't like needles, so they don't want to monitor their blood sugar levels. What challenges come up for you as the practitioner in these situations? Do any of you feel like an urge to kind of coerce or impose on? Is it justifiable? Do you know better than they know? Just remember we're there to be woman-centered and to stand by. Yeah. Okay. All right, so Sarah's come, you've taken her history, you found out, like you've discussed models of care for her, and now we're going to look at screening. So you might want to write up some blood tests for her to have some early screening or ultrasound. So let's go through what's standard in an early pregnancy screen. So on your blood, have you guys been writing blood test requests yet? No. Okay. So on your pathology form, often when people write bloods, they'll write everything out. So I've written that out for you. But in this instance, you can just write first trimester screen and the pathologist will know because it's such a standard thing. So I just put it all there for you. And we'll go through some of them because some of them are pretty specific to pregnancy. Have you done much on pathology and blood tests at all? Yep, a little bit. Yep, okay, great. So firstly, you want to confirm the pregnancy, which is looking at the HCG levels, human chorionic gonadotrophin hormone. And you'll do that test, so it's a hormone produced by the placenta and it confirms that the pregnancy is progressing. So if you check it at these weeks, you'll see the increase, which shows pregnancy is going on. Even after a woman has a miscarriage or a termination, there'll still be HCG in her blood for a while afterwards. So just also be aware of that. But if you test it over a couple of tests, you'll see it going down rather than up in that situation. And then we want to know her blood group and antibodies. We'll check this 3 times at least throughout pregnancy. But so have you studied blood groups and rhesus factors? So this is not all brand new for you. It's really important in pregnancy to know a mother's blood group because the baby might have a different blood group and there are a couple of conditions that can make that either dangerous for the mum or the baby. So the rhesus factor is a protein on the red blood cell of the baby's blood group. And so if a mother has a negative blood group but a positive baby on board, sometimes the baby's blood, if it mixes with the mother's blood for some reason at the placental site, it can cause the mother to go, whoa, there's a positive blood in here that I don't recognise. It's not meant to be in my body because I'm a negative blood group. And so the mother's body mounts an immune response and will attack future pregnancies of any babies that have positive blood groups after that. And so we know that now, and we will give anti-D, which is a blood product, twice throughout pregnancy prophylactically to prevent a woman who has a negative blood group a mounting immune response against future pregnancies. If you know that the father of the baby is a negative blood group as well, the woman doesn't need to have anti-D. In a public hospital system, you can never assume that who the woman says the father is the father. So that's why we still do blood testing, because the blood test doesn't lie. And there's an early screening test called a NIPT, which we'll look at in a second. In some states, you can find out what the baby's blood group is. So this is new screening, which is not routinely done in Tasmania yet. but that will avoid us giving anti-D to women who don't actually need it. She might have the baby and we discover all along both baby and mum were negative blood groups, so she didn't need all that anti-D, and it's a limited precious resource that we have. So ideally, we won't be giving anti-D to women that don't need it. But yeah, it has saved many pregnancies because of this factor. The other issue with blood groups is something called ABO incompatibility. Have you covered that as well? If a mother has an O blood group and her baby is an A or a B or an AB, same thing. If the blood mixes, then the baby can actually be born with jaundice or get jaundice within the first 24 hours, which is called pathological jaundice. And those babies can become quite unwell and anemic and often need light therapy. So that's another reason we want to know what the woman's blood group is in pregnancy, to just watch out for those things. And then on a full blood count, FBE, these are the main things I'm always interested in looking at. The CRP, looking at inflammatory or infection sort of levels, and I've put up what the level should be in pregnancy. It should be under 1.5. I'm always interested in platelets. Remember, pregnancy is a state of hypercoagulation. But likewise, if a woman's platelets drop too low, then that is also something significant. You want to, it's considered anything over 50 safe to have a normal vaginal birth, but I think it needs, over 80 for an epidural, because you need to be able to clot if you're having an epidural. So I want to know the hemoglobin. MCV is the size of the red blood cell, and if it's very high, it indicates vitamin B12 deficiency, and that can be a form of anemia. You can have a B12 anemia, so I'm always interested in that as well. And then, of course, iron studies, and I'd like to just go through that a little bit more. I've done a whole masterclass on iron deficiency in pregnancy, so I've just pulled out a few of those slides to go through today. So iron deficiency is low ferritin, right? You're all familiar with this? Yeah, good. So actually, if we wanted to check someone's iron stores, bone marrow is the best place to check that. That's the definitive marker for iron, but that's obviously very invasive, so we don't do that. The most easiest way to check what our iron stores are is through ferritin. And I always like to think of ferritin as your money in the bank. It's what you've stored away for when you need it, like your savings in the bank. And then, so iron deficiency would be not enough ferritin, like low ferritin, and it can be with or without anemia. So let's break that down a little bit more. So iron deficiency without anemia would just be low ferritin, yeah? And when you've got symptoms of low iron, that it means your body is now trying to budget. It's like, okay, I need iron here, here, and here. I'm going to start giving it to where I need to. One of the body's priorities for iron is your red blood cells. And so if we're showing a low hemoglobin, then that's really showing that body has budgeted wherever it can, and it's pretty deficient by now. So that would be iron deficiency with anemia, when you've got low ferritin and low hemoglobin. So it's sort of the last stage of iron deficiency. And so 70% of your body's iron is stored in your hemoglobin, as you probably know. Just trying to skip over this because I'm sure most of this is familiar to you. And so if we break down iron studies, serum iron doesn't mean much to me. I don't care much about it. It's like the money in your wallet. Your money in your wallet doesn't show what your financial status is, actually. It's just what you happen to have on you. That's what I think of as serum iron. Transferrin, I think of as a ute. It's my husband's ute. Its job is to go around looking for iron to take from the blood and put it into stores. And so in pregnancy, we want it to be between 2 and 2.5. If it's over 2.5, then that shows me your body is looking for iron. It's made more and more utes going, we need iron. It's looking for it. It's like iron hunger. Or if it's under 2, it indicates we've got too much iron, like the utes are all loaded up. We don't need any more. And the saturation is how much of the ute is being used up, basically, and optimally is 20 to 30% in pregnancy. If it's over 30, then that shows me a woman is over supplementing. And as you know, too much iron is toxic. And so we want to get that balance really right. And if you have too much circulating iron, your body will produce that hormone hepcidin to block you from absorbing iron. And so actually you can have someone who's anemic or iron deficient with iron block because they've taken too many supplements when their body can't handle it. So I like to keep a close eye on this for my clients. Total binding capacity is very similar to the transferrin. MCV, once again, that's the red blood cell size. So you need B12 to divide the cell. So once again, if your MCV is big, that shows a B12 deficiency. Yeah, hepcidin to not absorb too much iron. So what might cause iron deficiency in pregnancy? Well, it's kind of I don't know if you've heard of Professor Califala. He was a hematologist here in Launceston, did a lot of research on iron deficiency in pregnancy. So pregnancy itself, the hemodilution, remember the plasma goes up and your red blood cells stay low. And so that makes you look anemic, and I guess you are anemic. Heavy bleeding, nutritional deficiency, like not enough intake, or you're just not able to absorb it for some reason. Talked about that already as well. So in pregnancy, we have a baby that's taking a lot. You're growing a whole new human, and therefore a woman needs a lot of extra iron. And that's why I do a lot of iron infusions in my clients. You almost can't overload a pregnant woman because her body will just use it up. And she's going to lose quite a lot of iron during this process. And so that just shows you some of the intakes that she should be having. So let's have a look at an example here if you're trying to diagnose an iron deficiency in pregnancy. So first of all, I'm starting to look at her ferritin. Is she iron deficient? What do you reckon? 12. A normal, I would say iron deficiency is pretty much anything under 70, which is probably different to what your standard reference ranges are, but they're based on an adult male, not a pregnant female. So we have to bear that in mind as well. So yeah, she's definitely iron deficient. So is she iron deficient with or without anemia? So we look at the hemoglobin, it's also low. So she's iron deficient with anemia. So I'm concerned here. So I'm going to have a look at her iron. Don't care much about that. She hasn't got much circulating, but that's her money in the wallet. Transferrin, 3.2. So I just put it over here for you. Goal is 2 to 2.5. Anything over 2.5 indicates iron hunger. So that's also telling me she's looking for iron. Her body has put lots of utes out looking for iron to transport it. And then the saturation is also low. It should be 20 to 30%. So she's not over supplementing. She could use some iron. So that kind of helps you see how important it is and then what your management might be. I would be offering her an iron infusion and she'd probably feel a whole lot better for it. That makes sense? Questions? So platelets are good. So she's had enough iron for platelets. MCV is normal. And so she hasn't got a B12 deficiency. She's just got an iron deficiency. So we'll move on to some of the other pregnancy screenings. So STIs, and I've just written out there for you the different ones we would test for other infections as well as STIs that are important to know. Rubella is really dangerous in pregnancy. German measles, it can cause all sorts of birth defects and stillbirth. So we like to know if a woman's got immunity to that in early pregnancy. There's been a resurgence of syphilis in Tasmania, and so we're being asked to make sure we definitely check that again. And often these STIs are asymptomatic, like the woman won't necessarily know she has them and they can lead to all sorts of issues. So that's why we go through and check. And then blood sugar levels, we've talked about diabetes a fair bit. It's quite common. Women are already insulin resistant in pregnancy, and so we want to keep an eye on that too. And some women, there's very, very new information or evidence. A study came out last year showing that actually we probably should be screening women for diabetes much earlier in pregnancy, and you can get better outcomes if we do that. we used to think gestational diabetes only developed after 20 weeks when the placental hormones really kicked in, but there can be a lot of pre-existing diabetes that we're not aware of that can have a big impact. So, and yeah, urine, we want to check. Often women can have asymptomatic urinary tract infections in pregnancy too, and that can lead to premature birth. So we always like to keep an eye on urine, dipsticks, and signs and symptoms of that as well. And then you want to order probably an ultrasound, a dating ultrasound, and maybe the NIPT. So these are the different ultrasounds in pregnancy. Most women would have one really early on to confirm the pregnancy and to get an estimated due date. And the earlier the scan, the more accurate the due date is, because most babies haven't had enough time for differentials of genetics to kick in. Like I probably have really tall babies. And so 7 to 10 weeks, pretty much all of our fetuses are about the same size. So it gives a good accurate due date. And then women can have the combined first trimester screen, which is a blood test and an ultrasound, and it helps look for congenital abnormalities. It's fairly sensitive, especially to Down syndrome. Or women can pay to have a NIPT, the non-invasive prenatal test, and it's much more accurate. It's 99% accurate, but it's not covered by Medicare. So it's between $450 and $550 to have that, but it does have a high detection rate. It looks for the common ones like Downs, Edward syndrome, and Patel syndrome, but you can add in extras if there's a family history of other concerning congenital abnormalities. You can have them ordered as well. And then you do a morphology at 20 weeks. So that's a full looking at the whole baby to check that its heart and its lungs and its limbs all look normal. Often women only have the dating scan and the morphology. They're the main two, but more and more often women are looking for some of the congenital screening in the first trimester. And then if we have concerns as the pregnancy is going on with the size of the baby or movements or anything, we might do growth scans at 28 weeks, 32 weeks, 36 weeks. Over time, we can compare the baby to itself and see, is it growing as we expect it would. So that's just a summary of the different screenings that will be offered in each trimester. So in the first trimester, you'd be doing your bloods, some sort of dating or scan and first trimester screening, maybe the NIPT, maybe an early glucose tolerance test, which is to check for diabetes. And then if any of those screening tests come up, then the diagnostic follow-up would be an amniocentesis, and it's a needle aspiration of the amniotic fluid where they can get an actual diagnosis rather than just screening. But it does come with some risks of miscarriage and cramping. So that's why it's nice to avoid that if you don't need to. And then second trimester, you've got your morphology that we spoke about. Other screening tests would be the glucose tolerance test for diabetes, and would once again check full blood count, iron studies, blood group and antibodies, maybe vitamin D and B12. Some women don't want to have the oral glucose tolerance test. For that test, it's usually done at about 26 weeks, and they go off to pathology. They have a fasting blood test to check their base blood sugar level. And then they're given this, it tastes like undiluted lime green cordial. Like it's just this sickly sweet drink that they drink and have this big glucose overload. And then their blood is tested again 1 hour and 2 hours after that. So they sit at pathology a long time to do this test. Most of my clients actually decline it. They don't want it. It makes them feel sick. And so in that case, if they don't want to do that, I would lend them a glucometer and they would do their own blood sugars at home. My clients are very motivated and willing to do that. They would check them as if they had diabetes and record about a week's worth of fasting and after breakfast and after lunch and after dinner. And that would also tell me, are they having a diabetes response or are they not diabetic? And then you'd also offer some vaccinations. Whooping cough's offered between 20 and 32 weeks, and influenza can be had at any gestation. And then in the third trimester, RSV vaccinations offered. Once again, anti-D for any women that might have a negative blood group. Growth scans only if relevant. Once again, routine bloods again at 36 weeks. And then a group B strep screen is done. Has anyone heard of group B strep? So group B strep is a bacteria. It's a normal bacteria in our vaginas, but levels fluctuate up and down. And if they're high when a baby's born, the baby can then get colonized with this group B strep and become very sick. They can get pneumonia, meningitis, they can become septic. And so we test every woman at 36 weeks. We give her like a long blue swab. She goes and pokes it in her vagina, not very far, wipes it around. It gets sent off to the lab. It takes about 3 days to grow a result. And if it comes back as levels are high, then when she goes into labour, she's offered IV penicillin, benzoyl every 4 hours until she has her baby, which knocks off that high level of group B strep and is thought to prevent the baby from getting exposed to that. So that's also offered. Any questions on the screenings? Okay, so Sarah's come to you, you've done her history, you've written out some screening request forms, and then you're always going to look for educational opportunities at each appointment that you see her to talk through, maybe diabetes, depending what comes up for her history. This is a QR code because at the LGH, they have a link that they send all their women, and it takes you to a website where you can have a tour of birth suite. There's a little breastfeeding information video and a few other things, and all the education's on there. And apparently you're meant to be familiar with that. So I turned it into a QR code for you. So when you revisit the slides, you can go on there and check out what's offered here at the LGH. I think the LGH do offer some classes. I used to be in charge of the classes at the LGH, and then COVID hit and they shut them all down, and I moved over to the birth centre and have run classes privately for quite a few years. And there are other ones, hypnobirthing, calm birthing, some women will pay for. Yeah. Coming back to Sarah, now that we've gone through all of that, what are you most interested in about her? What things have jumped out at you? She reports mild nausea, fatigue, is otherwise well, has no significant medical history, but mentions her mother had gestational diabetes.
Gestational diabetes.
Yep. Why is that?
Are at a risk of developing.
Yeah, exactly. Yep. It's a family, it's probably genetic. Yep. Anything else? About her fatigue. Could be normal. What else could it be?
Anemia.
Anemia, thank you. Yes, and it often is such a red flag for me now. I'm always, yeah. Thanks. Okay, so we are now going to look at how to, the final part of the antenatal appointment will be palpating a uterus. Want to find out what the baby is, what's going on, listening to the baby. You won't be able to feel much at 12 weeks, as Sarah is, so now we're assuming that a woman's further along. And so the things you're looking out for and the process of palpating a uterus, ask her to empty her bladder. It can be uncomfortable. You don't need a full bladder to listen to a baby. You do for ultrasounds, but not for a palpation. So and that's a good opportunity to catch a urine and dipstick it if you want. So we don't routinely do weights and urines like we used to at antenatal appointment, but I still like to check in on those things. Not probably the weight, but the urine I'll check in on every now and then. It'll depend on the place you're working if they do that routinely. And then once again, you don't want her fully flat on her back, especially with a bigger baby in her tummy. It'll press on her inferior vena cava. So you might put a pillow under one side and sort of err her onto left lateral, or have her semi-recovered, not fully flat. Don't forget hand hygiene. I always ask permission, even if she's laid down and lifted up her shirt, I always, even it's my clients that I see for 9 or 10 months, I always say, can I touch your belly? Every single time. And she's never said no, but I had a client once who had a history of sexual abuse, and her tummy was a big part of that. And I didn't know. She'd never disclosed that to me until after she'd had her baby. But she said to me she appreciated so much that I always asked before I touched her. So can I touch your belly? And I always say hello to the baby. Hello, baby. first before I start poking around. And so there are some things you're looking for. You want to look at her skin. So you inspect, you palpate, you auscultate, and then you document what's going on. So the linea nigra is a brown line like this that develops on some women's tummies, all colours, all skin colours. Some women get it, some women don't. You might look for stretch marks, scar, shape, like has she had an appendectomy or anything else going on? So you can see stretch marks here, shape of her uterus. This was one of my clients in labour, but that's a really classic posterior presentation. So ideally the baby should have its back sort of towards the outside like this. But this baby was back to back and it looks like that in an extreme case. Like it looks like a ski. It's not a nice rounded belly. So looking at the belly can give you a good idea of what's going on the inside. And then when you palpate, you're trying to work out what position's the baby in, what's the lie, the attitude. Like, so we're talking about a longitudinal lie. Is it up and down? That's ideal. Or is it transverse or oblique? Not such an ideal position. Babies can't come out arm first. So we really want it longitudinal, either this way or this way, ideally head first. Position. So we're talking about, is the baby on the left side, the right side, posterior, and I'll show you a slide in a minute and explain that further. The presenting part, is it a head? Is it head down? Is it bottom down? Is it foot down? That's what you're trying to feel when you do a palpation. And then is it flexed with its head tucked under, or is it deflexed, or like really deflexed? This is much harder to birth a baby. You really want the baby tucked like this. And the best position is LOA on the left side. When we do labour and birth next time, I'll go through this a lot more and why, but ideally you want your baby on the left side. On the right side, we've got our liver under here, and the baby's often then kind of adjusting to that around it. And because that's not such an ideal, it's not nice and tucked, they often then during labour flip round back to back, and that's called a posterior presentation, and it makes labour long and difficult. Women get backache, labour starts and stops. So that's not so ideal. If a baby's on this left side, head down, those labours are usually nice and straightforward. So that's what we're hoping for in a baby. And then you're going to listen to the fetal heart rate, measure the fundal height. We'll take this here. Oh, I've got a video, I'll show you that, would be easier. And then listen to the maternal, feel the maternal heart rate as well, do the blood pressure and document your findings. So when we're looking at position, this is what I was saying. So we've got anterior is the front of your pelvis. As you know, posterior is the back. So when we talk about LOA, LOP, ROA, LOT, all these abbreviations, so it's referring to the left, the first word, left or right, refers to which side of the mother we're talking about. So L is left, so this is the mother's left side. Occipito is referring to the presenting part of the baby. And then is that anterior, which is out the front, or posterior at the back? So that's what these abbreviations all stand for. So LOT would be left occipital transverse. LOP would be posterior at the back, or direct OP. And you can see here whether it's tucked and flexed or deflexed. And then is it transverse, sideways? We don't want this. Actually, they're probably not so much like that. They're more often like that if they're transverse. Or breech, which is feet first, bottom first. So a bottom first is a complete breech. A frank breech, sorry. That's the wrong way around. Whoops. Okay, that's a frank breech with its legs up like this. Complete breech is when the feet are down and tucked. And then an incomplete breech is when one of the feet is coming out first. That's often it's often called a footling breech. It is not a footling breech, it's just an incomplete breech. I've done a lot of breech birth training, but you probably won't see that because not many people do breech births anymore. That's another reason for cesareans. I'll just show you this video.
Welcome to Medicine in a Nutshell's Guide to Conducting an Obstetric Examination. To successfully complete this examination, you will require a tape measure, a dating wheel, and a Pinard stethoscope. Before starting, take a thorough obstetric history. Position the patient lying down. A patient at term may become dizzy lying flat due to vena cava obstruction. Ensure the patient is comfortable and not dizzy or nauseous. The patient should be comfortable at a 30-degree angle. A successful examination is systematic and follows the rules of inspection, palpation, auscultation. Firstly, complete a general inspection. You are looking for the stigmata of systemic disease and also pregnancy-related illnesses. Here, note your general impressions. Does the patient look well? Do they look comfortable? Look at the hands and take a pulse. At this point, you may wish to take her blood pressure. Examine for signs of anemia or jaundice. Ask the patient to expose the abdomen. Adequate exposure is from the pubic symphysis to the xiphisternum. Inspect the abdomen closely. The abdomen is distended, consistent with a gravid uterus. Can you see any surgical scars, visible fetal movements, any striae or linea nigra? Note whether the abdomen is a convexity, suggesting an occipito-anterior position, or a concavity, suggesting an occipito-posterior position of the fetus. Palpation. Now measure the symphysis fundal height. Start at the xiphisternum and move down until you feel the fundus. Place your tape measure at the fundus and measure down to the most superior aspect of the pubic symphysis. This should be a blind measurement. Therefore, have the centimetre side touching the patient's skin so you cannot see it. The symphyfundal height is 36 centimetres, in line with the gestational age. Pregnancies are dated via scans. However, you may wish to use a dating wheel. Please see our dating wheel video on this link to see how to use this fully. Now palpate the abdomen for the fetal lie, presentation, engagement, and the quality of the liquor. Here, the left side feels flat and smooth and hard, consistent with the fetal back. The right feels lumpy, consistent with the fetal parts. This is the left occipito-anterior position. Use a bimanual approach. Stabilize with one hand and palpate with the other. The lie is longitudinal and there is cephalic presentation. Now palpate the fetal head. The head will be hard, round and floating above the pelvic brim. The fetal head is split into fifths. When giving a clinical impression of engagement, at term, it may be more difficult to palpate as it is distended into the pelvic brim. This technique may be uncomfortable for the patient. Finally, auscultation. Place the Pinard stethoscope over the anterior shoulder. This will depend on your clinical judgment of fetal position. Place it here for the right occipito-posterior position. Here for the right occipito-anterior position. Here for the left occipito-anterior position. And here for the left occipito-posterior position. Place the stethoscope in the correct position. Hold it in place with your ear so not to muffle the sound with your hand. Take the lady's pulse at the same time to ensure you're listening to the fetal heart rate. You are listening for rate and variability. You may wish to use a Doppler at this point. This completes your examination. Thank the patient and cover her up. Now, a guide to presenting the case. To present a history, there are 4 key areas. Number 1, give a brief history of the lady. State her comorbidities, her age, the gestational age, her BP and her urine dip results. Number 2, describe inspection. Firstly, describe her in general, and then describe the abdomen. Number 3, describe the uterus. Describe the symphyfundal height, the number of fetuses, the lie, the presentation, engagement, and the quality of the liquor. Number 4, assess the fetal heart rate using a Pinard stethoscope. Philippa is a 25-year-old prima gravida. She is at 36 weeks and 3 days gestation. She has a background of good health with no comorbidities. She is normotensive and her urine dip is negative. On general inspection, she is comfortable at rest. Clinically, there is no jaundice, anemia, or swelling. On inspection, the abdomen is distended, consistent with a gravid uterus. There is no linea nigra, and there is no stria gravidarum or albicans. On examination of the uterus, the symphyso-fundal height was 36 centimetres, which is in line with her gestation. There is one fetus with a longitudinal lie, cephalic presentation, and is in the left occipito-anterior position. The head was 2/5 engaged, and the lical was clinically adequate. The fetal heart rate was 130 beats a minute, with reassuring variability.
All right, so for our last 10 minutes, you've got, I'm going to rotate you through so you can come and have a feel of a pregnant uterus. Obviously not super realistic, but you can get an idea of how to measure where you might think the fetal back is, where the head might be. And I'll just call you up one table at a time. And while you're not up here having a go at this, I've got a few case studies, antenatal case studies on the table. So you can just have a chat about what might stand out to you. Some of the cases have some notes to give you prompts and some of them don't. So yeah, just consider pulling all of what we've done together. These are sort of classic cases that you might see in practice. So, and then we'll just finish together. So we're just about 10 minutes. Do you want to start?
That's a good question.
Motivational speech.
After the GP, the blood bank.
Because we're not going to. I have those.
Yeah, why not say anything?
I'll just make up things. Yeah, so I don't think I need any scans. Yeah, I don't want scans. Probably some radiation might hurt my baby, and yeah, I just feel comfortable doing it. To take a look at how's your progress with your pregnancy. So yeah, you tell me a bit.
Down over here.
All right, yeah, that's some normal, some physiological changes with the pregnancy. but yeah, I think you're doing good. And as I've seen with doctors earlier, we need to do protein scan. So yeah, I just
I'm trying to try and work out exactly this side.
You don't even need an excuse.
Like this is not what's
so safe. Have you heard about like
At least you guys can.
have you done an ultrasound before?
We're not doing
Yeah, so yeah, actually ultrasound is quite safe and yeah, it's just imaging to look at like how you receive the cell waste. It doesn't do any harm to you or your baby. Like we're just doing for screening. And, I'd like to do some research on like how ultrasound is.
yeah, so yeah, these are ones I actually.
You have an 8:30 class tomorrow.
I think she was 60 I use a Doppler.
I think she's staying at the event today. It's 2 hours.
Real
You have to go early. Don't try it. You might have to take into account that the aircon might be.
Alright, do I sound motivational?
So how would you describe and the plain
It is better if you spent it in long distance or no distance.
I think that
This is the actual stand.
I just.
great. Best night. Could you try getting Emma's drive?
We're staying in this room anyway, so it doesn't matter. I'm gonna go grab my bag.
Last week.
Yes, this is ideal.
Well, as soon as that's like, oh god, you know this guy's like yeah. But I don't have to do
That'll be like my vision was 6 emergencies baby and then I went wait back to 80. So I would to stay.
Oh, it's probably quite hard. Like that's still late. And cause I know she did as well. She told me. Actually, you research questions.
Yeah, like using one sided.
Emma and Debbie. Oh, do you want to see the email how she wrote this?
I also didn't.
Oh, can we see how she spelled our names? Oh. I generally don't think I've ever seen a name.
Do you guys want to come up?
Yes, sure. There was stuff on like I can learn and then the link draw
Yes, I did notice that. I was about to ask the same thing.
This is going to come up too.
Beauty, that's the word you use.
Oh, exactly. When you
the time.
Obviously, guys, obviously. Oh, you today with?
有没有搞错？我
Yeah, I remember.
我为了这个事我都取消了，然后他现在已经在这个手机。
很多东西。Oh, you talking about the yeah, well, I know what you're talking about. We learned in year one. Are you serious? What do you have K1? I'm not
Yeah, so you just said it's not a real life, it's not a life. 他是这样子看完这个 slide。If it was a rational thing, can you extra usually any context.
Oh, you're right. Yeah.
Really expecting the best of selling it.
Oh, don't worry about it.
You get the providers. You're right.
Less stress eating. Okay, guys, sorry, I'll just have your attention because we're about to finish. I'm going to move the model outside if anyone wants to have a quick go because we've run out of time. I will bring it to the next class as well. We'll do more hands-on. I just wanted to highlight next time we're going to do labour and birth, so they're the learning objectives then. If you have any questions, please email me about anything. Yeah, and thanks for your attention. Thank you.
I watched a video.
You're just going to work out what you think.
Alright, I'm gonna do it.
That's I've asked for like an infection.
Yeah.
I don't really know much about
It could just be any infection at a young age. They just delete it.
That's fair.
I'm assuming that they did.